Hello, everyone. A very good evening. Is my voice clear to all of you now? Am I audible?
Yes, Dr. Sidra.
Thank you
Assalamu
very
alaikum.
much. A very warm welcome. Walaikum assalam. Thank you very much, everyone. Sarva, thank you for joining in. Sujata, Dipti, Archana. How are you people doing out there? I hope you people are fine and things are going good. Did you people manage to attend the RCOG webinar yesterday? Thank you very much, Dr. Sabiha. Yeah? Did you people undergo the webinar? No? Must be busy, huh? There was a
I
webinar
know about the
yesterday,
webinar.
COG Part 3, for the discussion that was
Mhm.
going to be done. Few of my students, they did attend, and they came to the same conclusion that this time the Kingdom Exam UK exam is going to be digital. It would be online because of unfortunate second escalation and second wave declared. So it's going to be an online exam. So a few of the students from the UK, they have been registered for that. They've been sent the webinar and the tutorial is being done. How the examiner is going to conduct that. It would be first time. If at all it goes successful and things they go fine, it is practical, which I'm sure college would try to do. So they're planning next exam in early 2021, they said. Dr. Sabir, the link was in the was shared in the group way too earlier. It was a little earlier when I said that it is a planned webinar, though it was not something like it was live question and answer session, so it was hugely packed. But in the end, what was the conclusion? I would tell you guys. The conclusion was that this time, because of this situation, they're expecting that it would be like for next 1 or 1.5 year. So the college cannot postpone the exam further. For UK students, even it is not being on site. It is online for them this time. This is digital exam. They've named it as partial digital MRCOT Part 3 OSCE. So the first time it's going to be done this November for UK students. Why did they keep less people? Because they're saying people, they did say that you can take overseas as well. They answered that we are taking only UK people for this reason, so that we have less people who are taking exams, so that we also get accustomed to the system and we come to know that what are those difficulties we are facing because it's the first time. Therefore, if after that we'll be coming to know that how the things they go and we'll be in a better position to do it in a mass scale. They didn't give any date. However, they did say that 2021 early, we would be conducting the next exam that would again be digital and overseas would be included in that. Okay, so this was just the update. I'm sure when they give something in written and once the November exam, 4 of my students, they are appearing in November exam. And definitely I would guide you guys how the things would be. Meanwhile, keep on going slowly. We've got half of the September, October, November, and December. So 3 months, your preparation should be to the up to the mark, so that if at all they open in February, any online exam, you are ready to get registered. Okay, all of you got that? Yeah. Okay, so let me see. Jyoti has joined. Sarvat, Abir, Archana, Dipti, Divya, Dua, Dea, and Liana, Nadra, Sabiha, and Sujata. Dr. Sabiha, kindly write a message in the group so that everybody joins in. Reminder that we are starting the session. So friends, we are done with the sexual and reproductive health. We are done with the early pregnancy care, the antenatal care, maternal medicine, core surgical skills, post-operative care. And today we are going to do together 7 stations from management of labor and delivery. And then we will do postpartum problems after labor and delivery. Now, we've got 7 candidate students today who are going to present 2-3 stations. I will do consecutive to tell you guys that how do you deal with the negotiating station. I'm sure we will learn that how to negotiate better. Dr. Sabia in the main group as well, not only in A. Thank you very much. Thank you. And moreover, few structured discussions today are very important as well. So we'll do that together. Please take care of the time, be a quick reader, and organize yourself outside the cubicle. The management of labor and delivery. The topics are mashed with the postpartum as well, because at times this is overlapping labor and the postpartum. Remember that the important topics are negotiating stations. Either she's in labor, that you have to put the instrument, or cesarean section. Then there are some sort of a breaking bad news like postpartum, which came in my exam. That was in the labor module, that intrauterine death has occurred, and now you are meeting a mom after the event, and that is debriefing sort of a station. Then breech coming in labor, and you need to counsel her for the available options. Shoulder dystocia as an emergency comes. Generally, it is a structured discussion. Requesting home birth, again in the antenatal care, 36 weeks she comes. Today we are going to do this station. Perineal tear comes in the postpartum. We will do this station once we'll discuss postpartum care. The postpartum hemorrhage again comes generally with the structured discussions. You have to go through the algorithm. Umbilical cord prolapse, all the emergencies, they are structured discussion. Postpartum mastitis, I will do this station in the postpartum. This again is a recall station, an important one. Lady come with the engorgement and the pain in the breast. Postpartum contraception is very important. This we have done in the WhatsApp tasks, and this station generally comes with the counseling and can also come in the postpartum, also comes in the sexual and reproductive module. Again, postpartum headache, I will do with you guys in the next session. Again, it was a difficult station because lots of differentials had to be discussed. We'll do that together. Vaginismus can also be postpartum dyspareunia in terms of an episiotomy. Again, that's one of the stations which can come in exam. I've gathered up all the structured discussions from this. Why? Because there's certain things which cannot come as an SPT, like a maternal collapse. It's a recall station. So you can't do that in an SPT because the mom is collapsed, right? These stations you have to pen down, and you should be well versed with all these stations, specifically emergencies. What I did for myself was that I took out the printouts of all the algorithms, the maternal collapse algorithms and the emergency of labor algorithms, like cord prolapse, like that of shoulder dystocia, like that of postpartum hemorrhage, like algorithm of the uterine inversion. All these, make them together so that if some structured discussion comes in the last few weeks, you get to revise all your algorithms together. Okay, so please do that for you so that you are organized for revision. The related patient information leaflets from the RCOG, and rest you all know that we have to do from the NHS. Now, when it comes to the labor and delivery, please see the complaints. If she's in labor, that's a separate story. But if she's not in labor, then at 36 weeks, you take the history of the pregnancy. How had it been going? Please don't start from the first trimester. Your time gets wasted. Simply ask that, how had the pregnancy been going? Any concerns regarding the pregnancy? If you want to ask about some recent thing like recent ultrasound, recent blood investigations, which can affect your management plan, please do ask that. Now, if she's in labor, please settle her first, like I did in the postoperative complication. Please don't speak if she's having contractions, and examiner tests you for that. Okay? Offer her pain relief. Ask her to take deep breaths, and yeah, you're doing well. Encourage her, and in this manner, you come to the complaints after settling the complaint of the patient in the beginning of the station. Now, if she's in labor, do take some history of like onset, how much hours you are in labor, since when, how are the pains, if she comes with the preterm specifically. So do ask about, is it constant, is it intermittent? You need to rule out the differential of abruption. Always remember. Bleeding, since when are you having this bleed? What is the amount? Color, are you passing clots? Is it associated with pain in the tummy? Or is it painful to touch? Did you experience any dizziness or fainting episode? Now, if she comes with a leak, that is rupture of membrane, you're going to confirm that it would be, is it associated with any urinary tract infection, any associated vaginal discharge? Are you carrying a single baby, or is it a multiple pregnancy? Any history of increased water around the baby to rule out polyhydramnios, trauma, or were you doing some activity when you experienced this leak? Yeah. So these are all important questions for the prom history. Then you complete the obstetric history. How was the birth, mode of delivery previously? Gynecological history, if at all, it's an high risk case. Otherwise, ignore that, please. The medical history, the family, the surgical, the drugs, and the allergy. Remember, please, this part would not be in laboring patient. I'm going to test you now. In the laboring cases, when I would be mimicking that laboring patient, that how do you take the focused history? All right. Then the examinations like vital signs, abdominal, vaginal examination, they are very important in the laboring patient. And I have one example today where you get fixed up in laboring case when you don't think about that. And I'll just tell you in a bit that where did I make mistakes in certain courses and I learned from my mistakes in actual examination. Now, in management, if you have to negotiate a birth plan, do that. However, please give the pros and cons of each, and I'll tell you the exact way of negotiating today. In laboring patient, please don't leave her. Say, I'm right here to look after you. We as a team are here to support you. Some sort of these words. Okay? And if it's something like antenatal care, call her in the next birth, in the antenatal care, like maybe in 1 week time, or in the generally she's at 36 weeks, so call her after 1 week. Okay? Am I clear? All right. So what I've done is that I've made a little change because Divya had a commitment. So the first station is going to be, let me do the sequence again so that you all are ready. First is going to be Sarvat. Then it's going to be Ramya for Girija's place. Then it's going to be Divya. Archana would be fourth. Fifth would be Dalia. Then Jyoti. And in the end, Dr. Sabiha will rock the session. Yeah? Okay, so are we ready to begin? Are we ready to begin?
Yes.
Okay.
I wish I will rock the class without studying at all.
I understand, Dr. Sabiha, the commitments and children, I can totally understand, but we have to keep going, my dear. Since yesterday,
Yeah,
we've taken
inshallah.
the quarter. See,
Inshallah,
if suddenly they say that they are, because see, again, I would like to tell all of you that yes, students are suffering, but again, I would tell you all that college is suffering more. College is in such a great pressure because economy is suffering a lot. This is their bread and butter. So they are trying their 100%. Definitely they won't wait for people to get ready. Again, I would make you tell this point that in year 2019, when February exam and additional exam was announced, it was announced just 1 month earlier. So
no, we can understand, Dr. Sidra.
So
and we all love you and we all respect you, and we, inshallah, my kids, they started school now. I will start with the same.
So my request is that, see, if successful people would be who in 1 month time everything would be ready. Again, I say that maybe you people are not memorizing the things well, but at least your things are gathered, your folders are ready. So in 1 month time, you just do practice day and night, and you accomplish your target. However, if you people would be scattered at that time and things are not organized, then it would be very difficult in 1 month time, because I anticipate, because if things they go fine, definitely they're going to just give 1 month time and they'll open up an additional exam. So I don't want that we waste any time. Again, I understand the commitments and all. Please give 1 to 2 hours a day. That's it. Don't give like 3-4 hours at the moment, but organize your things. Make your templates ready. Okay. All right. Very good, Dr. Bindu. That's like my student. Well done. Okay. So can we have Sarbat unmute Sarbat yourself so that we can listen to your voice?
I have unmuted and I am so scared.
Yes. Oh, don't worry. Sarbat, it's been a long time that you've presented, right? Am I right? Yeah.
Yeah, I presented in the first session. I think the second discussion of that one.
Then there were some changes, and then Dr. Sabia, I think, did your tab. It was lots of commitments, so I can understand. So how are things? How is work going?
No, it's fine. But even with because of Dr. Sabia also, I am blaming her, but I am feeling less motivated because she is also not studying with me.
Ah, that's wrong. Give
Everybody
her this
in my
motivation.
group, everybody will blame me. From tomorrow, I will see them all.
Yeah, Dr. Sabia, because see, if one person, the main person goes easy, everybody is relaxed. So I can understand. I
Tomorrow, I will see
respect,
all of them.
yeah. And
I will fix
otherwise,
all of
Abir is
them
always,
tomorrow.
yeah, Abir is always available, I know, but because of some circumstances, she's occupied at the moment. So lots of prayers for all of you. Please stay in touch with each of you. So you're going to memorize. The best thing is that you now have the templates in front of you so that you can correct each other. Like the sessions I'm doing, now you can correct that this is what Sidra told, so you have to do in this way. Okay? So please
Inshallah.
practice with each other, and I'm sure you're going to do great. Okay, so all of us can listen to Sarwat, and we're going to have first station from Sarwat. Let me fix my notebook and the timer. All right. Okay. Yeah, so what is Sarwat having today? So first station, so no guesses, huh? Because you've got lots of topics.
Yeah.
Okay, right. So we are starting the 2 minutes time. Sarwat, please have a look.
Okay. Next. Okay. Next. Can I come to the first page?
Sure. Yes, please.
Yeah, next one, second. Yes. Okay. Hello, Anna Wilson.
Yeah, doctor, I'm Anna.
Anna, I am Dr. Sarwat, one of the doctor in the labor ward today. So,
Yes,
how
doctor.
may I address you?
Yeah, Anna is all right. Yeah.
And so, Anna, I can see that you are 27 weeks into your first pregnancy, and you came here with some pains, labor pains. Am I right?
I don't exactly know it's labor pain, but I'm having a little discomfort in my lower tummy, and it gets hard after like 5 to 10 minutes. Is it a labor pain? Don't tell me, doctor. Is it?
Yes, we have checked. You are getting uterine contractions, Anna. So, how are you coping with it? Do you want any painkiller medication now?
Yeah, the midwife just gave me, doctor. Thank you.
Can we continue? It's okay.
Yeah, please, yeah.
Okay, Anna. So I will definitely answer your concerns, and we will make a mutually agreed plan. But before that, may I ask few quick questions to know more about you?
That's okay.
Okay, Anna. So as far as I know, this is your first pregnancy, yeah?
Yeah.
So how far is the pregnancy so far?
Yeah, I'm around 28 weeks now. Mm.
So how has it been till now?
Nothing much, no problem up till now. Actually, I just came here to meet my brother. I'm from Romania, basically. So I'm on my vacation. Just 2 weeks back, when I was in my country, I had a raised blood pressure. So they started me on labetalol, but after that, it was fine. Other than that, I don't have any other problem.
Okay. Anna. So are you easy with the language, Anna? Do you want any translator or
No, no,
anything?
absolutely fine, fine. I come very frequently here.
Okay. Okay, Anna. So you told me your pregnancy has been okay up till now, and there was some concerns about your blood pressure.
Yeah, that's what I told you, that I was started with labetalol, and after that my blood pressure got settled.
Okay, and your recent scans have been okay?
Everything was fine. Yeah, they did today as well. They said that yes, the baby corresponds to the pregnancy time.
Okay, so now since how long you have this pain?
It's been around 6 hours. I started feeling like the same pain as we have in that of our periods, the cycle. I started like having discomfort in the lower tummy, and then gradually I felt that it's increasing. So I thought that it's better that I come here and get checked.
Yeah, that's
One more
okay.
thing,
And
doctor, I have a
yes.
little burning in my pee as well since yesterday.
Okay, I see, Anna. Yes, I will come back to this again. Okay, so can you please tell me the pain is continuous or it comes and goes?
It comes and it goes. Like right now, I'm not having pain. Yeah.
Mm-hmm. So have you got any episode of such pain before?
Doctor, it's coming again. Yes,
Breathe
yes.
and blow,
Now
Anna.
it's pain. You can feel that. Yeah.
Yeah, breathe and blow, Anna. Yes, Anna. Yeah, you are doing well. Okay, Anna. Then blow.
Yeah,
Do
it's
you
fading.
want some other thing? It's fine now.
No, it's okay. It's fading, doctor. Okay.
Mm,
Yeah, doctor.
you
Yes, please,
okay?
doctor. You were saying
Okay,
something. Yeah.
can we continue? Okay. Okay, Anna. So I was asking that have you got any episodes of such pain before?
No. In the pregnancy, no.
Mm-hmm. Okay, any leaking or bleeding from down, Anna?
Not yet. I felt a little discharge. Yes, it was a little light pink in color.
Okay. So have you got any treatment for pain or any discharge before?
No, nothing. I just had it today in the morning.
Okay, Anna.
Yeah.
Okay. So Anna, can you tell me, have you got any other medical problem for which you are routinely seeing your GP?
That's it. That too, this blood pressure raised in pregnancy. Otherwise, I'm absolutely okay.
Okay. And any allergies you have got?
No.
What about your blood group?
A positive. Everything is in my handheld notes if you just have a look.
Okay. Okay, Anna, any history you have blood clots in legs or lungs for you or your family?
Nothing like that, doctor.
Okay. Okay, Anna. So there are. Can I go to the next page, the examination one? Okay, Anna. So now, just according to your examination, yes, you are having contractions. They are like 1 in 10 minutes. They are slight contraction of the uterus. We call them labor pain. Your baby heartbeat are good, and like 20, according to ultrasound, is 28-week pregnancy. But as you told me, you are having urine, some burning in urine. So there are some pus cells and nitrate. Shows that you are having some urine infection also. Okay, Anna, are
What
you
do
with
you
me?
mean, doctor? That means that I'm just going to deliver the baby.
Actually, Anna, this is very beginning. You are when we check from down, and this is like your neck of the womb is slightly open and softened also. So it shows that it is just starting the labor pain that we call the peritum labor. That, but we have some certain things to manage that situation with you. Okay, Anna.
Yes, please do something, doctor. I don't have anybody here. Moreover, I don't want baby to get delivered, of course. I mean, the baby at this time would be able to survive.
Yeah, I can understand, Anna. I will answer all your concerns for this. Actually, usually labor pain usually start after the 37 week, but in around some women it can start before. So that is called preterm labor, and there can sometime it can start on its own, and sometimes there are some reasons also. And but for now, for this, I will speak with my consultant, and we will offer you admission for this. And we will make sure that baby's doctor will see you and check discuss with you about the prognosis also in case if you deliver this time. Okay. And I will have to make sure also that we have an arrangement of the cot for the baby, and we have that neonatal unit here to see that if the baby arrives at this early stage, so how we have
what
to
is the
manage
neonatal unit? I mean, my baby is
the
ill.
babies, the unit that care of the small babies who are delivered early or just to for take care of them.
Okay.
Okay.
So,
Okay.
I mean, nothing can be done to just stop this at the moment.
Yes, Anna, I will discuss with you. So the thing is after admission, so what we will do is we have some medication to slow down or stop the labor also, that we use certain medicine for that. And in that is usually we are using this medicine to take the time for that we will give some injection to you to help your baby's lung to mature. So in case if you deliver, so your baby will be in the better situation to cope with that, and there will be less breathing difficulty and feeding and infection problem that may happen with premature birth. Are you with me, Anna?
Yeah. Okay,
And with that, if we realize that you are still going to deliver within 24 hours, we have there are another injection that is called magnesium sulphate. That is also we are giving for the protection of the brain of the baby. This injection, if it is needed, it will be given to you, and you will be monitored for your BP and pulse and certain things to see that this medicine is not harming you. Okay, and one more thing is to help protect from the bug infection. We will provide you with the antibiotic also.
this all would be
Okay.
done now.
Yes. After admission, we will start doing all these things. I will ask my consultant to see you and the baby doctor also. Okay, Anna?
All right.
So if you progress in labor, so we will make sure to support you. You need and whatever is there, and to avoid certain maneuver in the labor that we are trying to avoid because baby is premature right now, like applying some instrument to for delivery or putting some clips on the baby's head to check for the baby's condition and all those. Okay.
Okay, right. So, how much is the chance that the baby would be fine and would be surviving in a fine manner?
I will connect you with the baby's doctor so he can discuss with you in detail about the baby's prognosis, Anna, at this stage.
All right.
Okay. And one more thing is I want to discuss with you in case if we find there is some issue during labor, and for example, problem with the baby's heartbeat or failed progress, or if we see that it is not possible to deliver the baby, so it may be we may need to expedite it by the help of some one instrument that is called forceps or sometime in case of emergency cesarean section also. Are you with me, Anna? Do you want me to discuss that? So yes, so that also can be there in cesarean section. Yes, being operation, it has its own problem that can happen with you, longer stay of in the hospital and some injuries to the organs and some risk of bleeding and infection also. Okay, Anna?
Okay, doctor, do something,
Okay,
please.
yes, we will do it. I will discuss with my consultant, and I am here around. Just read this information leaflet about the preterm labor, and I will come back with my consultant to make all the arrangement for you. Okay. Okay. Thank you. Thank you.
All right. How was it, sir?
I don't know. I got confused. Tried to sum up all the things of preterm labor.
I understand. So I wanted to do the station in the beginning so that we get in a sequence, then we come to the labor, because this was the only topic which was different in labor, a preterm labor.
Yeah.
But nevertheless, you did touch many of the points. It was good. However, in the beginning, there was a little
One thing I
confusion.
want to ask Dr. Sidra,
Yes,
was
ma'am.
there any empathy in my sound? I am so much concerned about empathy. I know it is very difficult.
I wanted you to do breaking bad news.
Okay.
I've written this in the
Oh.
template as well. It's a bad news for her.
That is
I
absolutely
gave
not in my mind that we have to do breaking
yeah,
bad news.
I
Yeah.
gave you in the beginning this clue when you spoke the word that you are having some labor pains here. I said, oh, is it a labor
Mhm.
pain? Yeah. So this is something
Oh,
which I don't know.
right.
So if I
Yeah.
don't know, that's why in the very beginning, in the first sentence, I gave you that
Mhm.
clue that you could have said it in this manner, that you have come
Mhm.
here with some sort of tummy pain. So it can be anything,
Mhm.
right? A tummy pain does not necessarily mean at 28 weeks it's a preterm labor. So you have to go slow in the station, not in the agenda
Mhm.
mention that, because you have to assess that what
Okay.
does she know, right?
Yeah. Okay.
Yeah.
Yes.
So
Yeah.
I wanted the breaking bad news for which I would cut point for empathy. Rest, I'll just tell you that where things were better and where we could have improved a little as well. Okay.
Mhm.
All right. So to begin with, when you entered into the cubicle, you were thinking that I would be in pain. So you were taking a little pause. So I purposely did not mention because it's 1 in 10 minutes. I
Mhm.
purposely did it in the center. Because you were taking
Mhm.
pause that you're having some pain. So you were expecting like in a post-operative module, I will just bombard with, oh my God, doctor, I'm having pain and all. Yeah, I could sense that
Yeah.
from your pauses in the beginning that yes, Sidra would be coming with some pains here. So I have to be a little, quiet. So go with the flow. When you entered into the cubicle, you asked about the name Anna. You confirmed that. Is it Anna? Yes, I am one of the doctors in the labor room. So I've gathered that you're having some labor pains. So avoid this labor pains here.
Yeah.
Okay.
Okay.
So say I've gathered from your case notes that you're having some tummy discomfort or tummy pain, and you're here to get evaluated. Am I right?
Yes.
Okay,
Okay.
so this is a better
Mm.
agenda, specifically in preterm labor. Remember, in labor, it's fine. But in preterm labor, you have to go a little slow because it is something like very surprising for the mom that it can be. As I said to you as well, I had periods like pain. So the primary
Mm.
gravida doesn't know that it can cause the birth of the baby at 28 weeks as well. Specifically when she is in the vacation time and she doesn't expect that this is my delivery time. Okay?
Yeah. Right.
Now, one more thing that you did ask about the painkiller, the concerns, that was all right. I will tell the good points first. You spoke the word quick information gathering. That was very good. This word quick was very good. You confirmed that, yes, I'm into my first pregnancy. Uh, these handheld notes were provided to you in exam as well. So whatever
Mhm.
information is provided to you, it's better not to ask that information. It's better to repeat that information. Like, I've gathered that you're having some raised blood pressure and you're taking some medicines. Am I right? Yeah. So other than that, do you have any other problem in the pregnancy? Any concern regarding the baby, the ultrasound? I've gathered that your blood group is A positive. So I've gathered your blood group is A positive is a better sentence that shows to the examiner that you have read the scenario well. Okay, rather than asking, may I know about your blood group? Even if you ask, that's not a problem. But telling you that an ideal way is that you tell the examiner that whatever has been provided to you, I've registered that well.
Mm.
Okay?
Actually, I forgot because these papers, these slides passed away, so I forgot what I read there.
Okay, no problem, no problem. Then you asked about the language understanding. That was a good point. You did ask about the burning pee and you registered that and gave antibiotics for that as well. That was all right. Other than that, the preterm questions were a little lacking, which I'll just tell you in a bit that what were those in points to improve. Then you did take the medical history. You did take the family history. However, the surgical history was missing. That's important as well, specifically if she has to undergo cesarean section. Okay, so surgical history is not to be missed. You did take allergy as well. Other than that, it's all right that if you miss everything. But here, I would also ask about the support. Why? Because she's on vacation, right? So is there somebody to accompany her if at all admission is required and further if, later the baby is delivered as well. So may I know that who is here to support you? So something like the baby is delivered, right? So whom she is with, because she is not in that of a second stage labor where pains are going, she's talking to you like in a 10 minutes interval, right? So
Yeah.
support can be asked here. So it is like because this patient is not at her place, she's not at her country. Therefore, you can ask the support here because this is going to give you the clue that do you require to give support or do you require to give her that that we are here for the baby if a newborn baby and she requires support and how the things, where she's living. So anything she comes up with, you should ask support in this station specifically.
Mm-hmm.
Now,
Okay.
immediately after completing the history, you came to this part that this shows that you're having some contractions and these are labor pains. Here, it was very abrupt. Here, give 1 or 2 signposting, my dear. Okay, 1 or 2 signposting. You're concerned regarding telling the preterm labor. I would like to explain it a little more, that what does that mean. You did admit the patient, and you said the baby doctor would be looking after you. Hold on. Yeah, the baby doctor would be meeting you as well. You did arrange for the cot. You did give steroids. You did give magnesium sulphate. In the end, again, when I was saying that baby, how would be the baby condition, you did connect me to the baby doctor. That was a good point. You did tell me about the chances of spontaneous vaginal delivery and the cesarean section. Both can be there, and forceps can be applied in this gestation. You were right. You would be avoiding the clippings and these vacuum. That was good point as well. Now let's see what could we do better in this station. Firstly, sir, what age was missed today? You said it's Anna Wilson. I'm Dr. Sarwat in the labor ward. So I've gathered here, you said with the labor pain. So I would say that you're having some pains. Do you want some painkiller? I said that midwife did give me. No age was confirmed. So don't miss your basics, okay? So in the beginning, if you had to say that, how could you have said that better? Hi, Anna Wilson, 26 years. Yeah, I'm Dr. Sarwat, one of the doctors in the labor ward duty today. So I've gathered that you're here because you're having some tummy pains. Am I right? Yeah, surely in the next few minutes, I would be asking a few quick questions to know more about you, and would definitely try to evaluate the situation, would come up with a safe management plan. Would that be okay? Yeah, Anna, can I ask a few questions if you feel better? So this is how I would go. So age confirming would not be missed. This is a very basic point, okay? So you missed that in the flow. I wrote down that you did not confirm my age. Then again, I've written that avoid using the word labor in the beginning, provided it's a preterm labor, because it's not something which she knows. You should say a tummy pain. A tummy pain can be anything. So don't say labor pain. Say you're here with some tummy discomfort and pain. Am I right? So this is the ideal way of making an agenda. Now, when I mimic pain, friends, I would like to ask a question that when I was having my pains in the tummy, what did Sarwat say? And did anybody notice that?
Ma'am, actually she encouraged that take a deep breath and all the things,
Yeah.
which should not happen in preterm labor.
Yeah, thank you very much, Archana, for noting down. This is the difference between labor and preterm labor. The words, yeah, Anna, you're doing good. Yeah, Anna. Yeah, take a deep breath. Yeah. All these words are for labor pains. You encourage when she's 37 weeks plus.
Oh, yes. I know that. I don't know why I did this.
In a preterm labor, you never say you're doing good, because in preterm labor, if you're encouraging, you're losing your marks. What you can say is, yeah, please take the pains. I'm right here. Okay, that's it. Okay, and you say, do you need any painkiller? Because if you're saying, yes, you're doing good, this is a statement you have to speak in the labor, in the term labor, when you do encourage that, yes, labor is going good. Here we need to stop these pains. Okay, all of you, did you note this point? So again, this is against the patient's safety. You don't have to encourage the preterm labor. Did you all note this? Please be active in the chat box so that I can understand that you people are with me. Dua? Yeah? Dr. Sabia noted that in preterm labor, thank you, Dipti, you don't have to encourage the pain. Okay? You just have to say that, yeah, okay, all right. Do you need any painkiller? So encouraging, you're doing good, or take a deep breath, these 2 points would be in the term labor and not in the preterm labor, okay? So this was point which has to be avoided at any cost in exam, okay? Thank you. Then I was expecting that after the history, I would have said that, you know, how I would have gone through this is, Anna, thank you very much for informing me about the details. The midwife has just examined you and I've been provided with examination. I can see that you're here alone today. I have some difficult news to discuss with you. Can I proceed? Sir, I would say these few sentences before coming to this. Okay, right? This is why she would get ready. Okay, something serious is coming ahead. Now I would be saying that the examination reveals that you're having some tummy pains. However, the vaginal examination shows that neck of the womb is getting dilated and it's getting thinned out as well. What it means is that you're going into the labor and the neck of the womb is getting prepared for delivery of the baby, which should not happen less than 37 weeks. I'm afraid we call it as preterm labor. Now I will take a break here. Now she will come up, oh my God, doctor, how did this happen? Why did this happen? Now I would be saying the examination reveals that you're having some infection in pee as well. There can be many causes. At times there are no causes at all. But we have to take the situation from this point onwards by the team of doctors taking care of you, my consultant, the baby doctor, and if required, the anesthesia doctor as well. Would that be okay? We need to admit you at first place. So from here, I will start the management plan. Got that, Savat? How I'm going to take the breaking bad news, my dear? Then I will explain what preterm labor means. Explanation of the preterm labor was a little ambiguous. I will tell her that what does it mean? She's a primigravida, right? It's getting dilated, it's getting thinned out, and getting prepared for the delivery of the baby. So this is how you speak up and you make her come to the preterm labor diagnosis. Now, after this, I will tell her that what do we have to do? The first thing is that I will inform the baby unit. I will not say the neonatal unit. I would explain that I would inform the baby unit at once to ensure the cot availability. If at all the baby is delivered at this point in time, requires the environment same as inside the mom's womb. If it is not there, I'll discuss with you in detail. We might have to do a transfer to the nearby unit where the cot is available. I'll talk to you in detail after confirmation from the baby unit team. This is number one. The first thing you always do when the preterm labor, the case comes to you. For the baby maturity, lung maturity, we would be giving you the injections, we call them steroids. One injection right now. I will be very clear, Savat, in this. Just right now, because the clock has to be started, this is your patient safety. That's why I asked somewhere in between when you said, we will give steroid, we will give for the brain protection, magnesium sulphate, then you said antibiotic. I said all would be done now. So I wanted clarification. We are going to start the baby lung maturity injections just now, and we'll repeat the second one in 12 hours time. If at all the contractions still proceed after that, we might give you relaxants for the womb to make it calm until and unless your effect of the lung strengthening injections of the baby, they get completed, Anna. Or if we require transfer to the other baby unit. Now, what am I doing? I'm telling the examiner, I know very well that what are the indications of the tocolysis. Did you people get my point? Yeah? Now I'm telling the examiner that what are those two indications for the tocolysis. So this is your applied clinical knowledge. Then I will say that at the moment, if we are able to stop, we will just observe you. If at all it's not stop, either the neck of the womb goes beyond 4 centimeters, or we anticipate that you're going to deliver in next 12 to 24 hours, we would give another injection for the baby brain protection. So that's why I asked you that would that be now? Magnesium sulphate won't be now, right? So again, I wanted you to clarify your applied clinical knowledge to the examiner that yes, steroid now, yes, tocolysis for 2 reasons now, and magnesium sulphate if at all I go beyond 4 centimeters, or if I'm ready to deliver in next 12 to 24 hours if the contractions are so quick. You have to give antibiotic now. You have to speak it up for the infection in the pee. That's understandable. But at the same time, I wanted you to speak that if you go into labor and you cross the 4 centimeters, we might have to give some other antibiotics to prevent the infection in the baby. So I'm talking about GBS prophylaxis now. Okay, so these timings were not clear. What I understood was that everything would be now. Steroid, magnesium sulfate, antibiotics, everything would be now. So your applied clinical knowledge has to be very clear. Number one, again, I would repeat, steroid just now immediately, right? Magnesium sulfate if she is like 4 centimeter above, or if the contractions are more. Tocolysis, just to cover the steroid, I will speak the same sentence, right, as I told you. Then it's going to be your IAP, if again she's in established labor, intrapartum antibiotic prophylaxis here. Then you can say, if everything goes fine, we would try to deliver normally. And if at all there's some concerns with the baby heartbeat, we will talk to you the requirement of the cesarean section as well, but it's way too early to comment upon that, Anna. We are here in touch with you, and how the things they go, we'll discuss with you accordingly, right? Again, when the question came that, no, Archana, she did tell about the allergy. Yeah, she did ask about that. Okay, now if she asks about the how would be the baby and what is the prognosis of the baby, make a pet sentence. You cannot comment upon that. You say, Anna, at this point in time, it's very difficult for me to tell you that how the baby prognosis would be. However, the baby doctor would talk to you. It depends upon the time at which the baby is delivered, and along with that, the weight of the baby, it does matter as well. We would, as a team, be supporting you in the situation, and will connect you to the baby doctor who will talk to you in detail and address your concerns. Would that be okay? So do tell the 2 things they matter, that at what gestation the baby is delivered, and at the same time, the weight of the baby. So make your pet sentence to answer, because in preterm labor, always this question comes to you. So these were a few points which we have to improve. I will repeat that again. Don't miss the age. Please don't encourage the labor pains in preterm labor. Do a BBN in the preterm labor. Always first ensure the cot availability, the NICU availability. Ensure the timings of management of your drugs, that is steroid, magnesium sulfate, tocolysis, and the intrapartum antibiotic prophylaxis. If it would have been ruptured membrane, then you would have added erythromycin as well. Okay, so these were a few points which we have to improve together, and do mention intrauterine transfer point somewhere in between that might be required. So this was communication with the patient and the relatives. Greeting was all right. Missed the age, which we will not miss, Sarvat, next time, I'm sure. Don't encourage labor pains in preterm labor. The reason I've made it in red is that this would make you fail the station if you encourage the labor pains in the preterm labor. Your repo building was fine. Your speaking volume was fine. Yes, I was scared and upset, so I wanted a little BBN. Your empathy was all right, except those big, I would say, mistakes which cannot be forgiven in exam, like encouraging labor pains and not doing BBN. These 2 points make you go borderline in the empathy. Otherwise, your tone was fine. I didn't have a problem with the tone, server, today, but missing these 2 points was a little, we need improvement in that. You were fine in your history. When did it start? One thing I have to tell all of you, please. In labor, you don't have to miss one thing, which I will tell you that what did I do in a college course. And so Andrew was there in the station, and I still remember his face by telling me that if you're going to do this, Ali, you will have trouble in exam. And I still remember that day I caught this point that in labor module, in history, always ask that when did you have your examination? Why? Because in post-op, it's fine. In other modules, for example, a pelvic mass, it's fine. For example, it is some sort of an examination for the VIN or some lichen sclerosis vulval examination, it's fine. But remember, I caught this point and I never forget now that labor is a continuously changing process. You people understand this thing? So always ask in your history, may I know when were you internally examined? And I'll prove that today, that what happened with me when I'll come to that station, and how you have to keep this in your mind. All right? Remember that maybe, Sarbat, I didn't have any change here. Now, if this examination was like 4 hours back, yeah, and she's having continuous contractions, would you like to say that I would like to examine you again? Probably because I would like to confirm the findings because you're having pains continuous. Am I right?
Yes,
And if I
definitely.
say,
Yes.
very good, now you understand. Now, if these findings, I just say that it was just like 15, 20 minutes back, I was examined by the midwife, you would be all right. You would say, okay, thank you. You get my point? So remember, this is a mistake which I did in the college course, and I never forget that labor is one thing in which in the history you have to ask for sure. May I know when were you last examined? Clear? Everyone, did you note this point? Please don't make this mistake, because when I'll come to that station, I'll tell you what mistake I made and why did I get borderline in that mock station in the college before exam. Always we learn from our mistakes. So in labor, it can be continuously changing thing. Please don't make that mistake, okay? So do ask that when were you last examined. About the bleeding, I didn't have, so it was all right. I told you that it's just a pinkish discharge. You did ask about the medical, the obstetric, the gynae history, a surgical drug, personal history. Yeah, BMI also I would like to know. Why, Sarat? Because it can also affect the delivery plan, right? Or at least the anticipated complications. Am I right? Yeah. So just
Yeah.
height to weight ratio quickly ask. And this social support I will add here, because this patient, specifically when she's away, had she been no history being given about these travel and all, it would have been okay if you missed that. But in this case, she's alone, she's on vacation. So we need to know that how the things are, right? And this examination, if you would have asked me, I would have said just 15 minutes earlier. So it would have been missed. That's okay. Now, about the safety, all points were fine. You treated the urinary tract infection by antibiotic. For mother, antibiotic was necessary. For the baby, steroid, tucolysis, magnesium sulphate. Tucolysis was missed. I wanted you to speak that. IAP in labor, I wanted you to speak that. Now, when you come to the applied clinical knowledge, I will go stepwise. I will do the breaking bad news, explain the condition with the breaking bad news, and will tell what does it mean to the mother and what does it mean to the baby. I will tell her that for you, it can be a normal birth. It can be a chances of cesarean section. For baby, it can have the baby because of early birth can have certain complications like breathing difficulty, like infection, and in the long term. So I will speak one line. What does it mean? Now, the management options for the mother, I would say, is antibiotic because she's having urinary tract infection. And for the baby, I'll speak of the same thing, that right now we are going to start with the steroids. And then it is going to be tucolysis to calm the womb for completion of the steroid action, or if at all we require transfer to the nearby unit for the baby cot unavailability. Magnesium sulphate, again, I will justify after 4 centimeter. Interpartum antibiotic prophylaxis, only when she goes into established labor, okay? Moreover, I would say that NICU availability I have to take. So all these points, I will organize myself so that I speak up in a structured manner. Don't forget the breaking bad news, okay? Breaking bad news for the preterm labor because she's not ready for that. It's always an upsetting news for the patient to go into preterm labor. Please keep that in mind. That gives you an additional advantage in rapport building as well, and it enhances your empathy in the station as well. Okay, so how the outline goes, it goes like introduction. If she's in pain, settle the pain. If she's not in pain, settle whenever she has the pain. Quick focused information gathering. Yes, do the BBN signposting, offer the support and management of preterm labor in terms for the mother, in terms for the baby. Am I clear, friends, how the preterm labor would be? Yeah. Now the PPROM, if it occurs, the same station you will go with, yeah, but you will go with adding erythromycin here. That's the difference. Okay, that's the difference. And moreover, in PPROM, additional thing would be that you observe till 34 weeks, and in 34 weeks, you will do the induction of labor. This would be the difference if PPROM comes in exam. Okay? Any questions, please, from preterm labor? Are you people clear now? Are you in a better position to handle the preterm labor scenario now? Yeah?
Yes, Dr.
Yes.
Sidra, last which, can I see the last page, Dr. Sidra?
Last as in outline?
Yeah,
Yes.
yeah, outline.
Yes, my dear, please, yeah. All right. So any questions from preterm labor? I hope now it's clear. I went into detail because this was an exam station and you should be very clear that how you're going to, no, Bindu, it has to be now to cover up the steroid. We don't take time. With steroids, we immediately tocalize so that the steroid action, it starts like we get at least, 24 to 7 days time, 24 hours to 7 days.
Policies, actually, I didn't talk about intrauterine transfer as well.
Yeah. So these two things you have to talk about. Okay. One is to completion of the steroid and second is it's going to be intrauterine transfer if required. All right. These two things. Thank you very much, Sarvat. It was a good station. Your applied clinical knowledge. Hold on, guys. Let me take my honey water. All right. So in terms of the scoring, information gathering, other than the surgical history which was missed, I will give you fine score in that. It was 2 by 2. In the patient safety, just missing up the tocolysis, I will give you somewhere 1.2 out of 2. A little more than borderline, a little less than passing. Communication with the patient, I'll have to give, because of not doing the BBN and encouraging the pains, these two mistakes I cannot forgive. So it would be less than borderline, I would say, just because of these two mistakes. Okay. Otherwise it was fine, but these are two big mistakes. I cannot spare these two big mistakes. Okay. I'm going to be strict now. Definitely in exam, you'll never forget that I don't have to encourage the preterm labor and I don't have to miss the BBN there as well. And what is left? Applied clinical knowledge. Applied clinical knowledge, IAP was missed. I'll give you borderline in applied clinical knowledge as well. Okay. Otherwise, the steroid, just timings, I would like to know so that we are in a good position to start with. We have to talk about the risk of PT because hypertension in this case, see, Dua, what happens in exam is that they don't give multiple things in one station. For example, if they've given the hypertension, they've given as well that it's stable. On labetalol, she's doing good. Okay, so if things they give specifically that it's preterm labor and hypertension is uncontrolled as well, it would be very difficult to manage in 10 minutes time. So when they give some additional thing, they say that it's stable. When I said that it's stable, so that means that now your focus has to be on preterm labor. Yeah, you can mention one line that your blood pressure controlling medicines would be continued. That's it. Okay, that would be continued, and we look after that element as well. Or in the MDT, you can ask the doctor of the domain would be also taking care of you. Got that?
Okay. Okay.
Otherwise, don't go into detail, Dua, because it would be very difficult to manage the station then.
Okay. Thank you so much.
Okay, thank you very much. All right. Any more questions, please, from this station so that we move to the second station?
One question.
Please, my dear. Yeah, Jyoti.
Would it not make sense to give her tocolysis nifedipine if we are giving, then change labetalol to nifedipine, something like that?
No, tocolysis dose is absolutely different than antihypertensive, my dear.
Yeah, it is. Yeah. So like you continue labetalol as well as nifedipine.
Yeah. Here, I won't even prefer nifedipine here because if magnesium sulphate is being given, I will prefer atosiban. We can't give nifedipine with magnesium sulphate, right?
Yeah, you can't give.
So it's better to give atosiban here.
Yeah, but you're not giving it right now, so it would be like.
But tocolysis, no need to mention if it's not a structured discussion. You say we will give you medicines to calm the womb or to stop the contractions until the effect of the injection. Yeah, you need not say that. Yeah. Because she doesn't need to know what medicines you're going to give. It is you telling the examiner that yes, tocolysis would be done. So don't put yourself into difficulty, right? Yeah. Okay. All right. Thank you, Jyoti. Thank you. Any other question, please, before we start the station number 2? Dan? Okay. Thank you very much, Sarah. Just practice on these tiny points which I've told, and I'm sure the station will be perfect. Okay. Thank you very much. All right, for the station number 2, who do we have? We have got Ramya. Hello, Ramya.
Good evening, Sidra.
Good evening. How are you doing? How's the
Yeah.
work going? Lots of duties, huh?
Yeah.
I can understand. So Girija was having some commitment, so she messaged me that you're going to replace her.
Yeah.
Was it a volunteer replacement or was it a forceful replacement?
Yeah. She had some commitments. I'm also on call now, actually.
Oh,
I told
really?
me to call after 9. I thought I should finish my station and leave.
Okay, I understand. Okay. So let's begin the station and let's see what do we have to discuss today. Okay, so I'm starting the 2 minutes time. Please.
Hello.
Hi, doctor.
Hello. This is Dr. Ramya, one of the doctors been in duty in the labor ward. And is this Amanda Phillips I'm talking
Doctor,
to?
yes, I'm Amanda, doctor. I'm having severe pains, doctor. They're not stopping at all.
Okay, Amanda, you're doing good. Okay. Do you need any pain relief, Amanda?
Yeah, please do that.
Okay. I'll ask the midwife to give you some pain relief. How are you coping up now, Amanda?
It's slightly getting lesser.
Okay, take a deep breath.
But it's so frequent, doctor. It's not letting me breathe even.
Yeah,
After every 2 minutes, I feel that I'm having pains.
Okay, take a deep breath, Amanda. You're doing good. Okay.
Yeah, thank you, doctor. Yeah.
You okay to talk?
Yeah, I am. Yeah, doctor. Yeah.
Okay. Amanda, I was just called with the midwife to see you around, because she has some concerns with you. Is it okay? Can we talk about that?
Yeah, please. Yes.
Amanda, is it okay if I call you Amanda?
Yeah, that's okay.
Okay. I can straight from the observations that you're 27 years and you are into your labor. And the midwife observation shows that your neck of the womb is dilated, opened up to 6 centimeters, and she observed the baby as poured inside.
Oh, poured inside.
Yeah.
That's why I'm having all this green color on my legs and all.
Yeah, Amanda.
Oh, I see. But why did baby do that? I mean, what's the reason behind that? Is the baby well?
Now, of course, we do connected the heart tracings with the baby. I could also see the heart tracings we call as CTG that shows the baby is at the moment happy. Okay.
Okay. So, I mean, I'm still having pain. So, what would be the? I mean, what would be the next steps?
Okay, Amanda, is it okay if I ask you a few questions so that we can discuss about the safe management plan?
Okay.
Be okay with you?
Yeah, that's okay. Yeah.
Okay. Amanda, can you tell more about this pregnancy?
The pregnancy didn't have any problem at all. I mean, all my my checkup was with midwife. I didn't have any problem. All the ultrasounds, they were fine. I went into labor myself in the morning, and it's been like 5 hours ago. I came and I was like 2 centimeter at that time. 1 hour back, I was checked again, and you saying that it's like 6 centimeter. I think I'm doing great.
Yeah, you're progressing good, Amanda. And have you been pregnant before?
This is my post-pregnancy.
This is your first pregnancy. Okay. Yeah. And Amanda, may I know when was the last scan done for you?
Yeah, that was done just like maybe 36 weeks.
Yeah, everything was told to be fine, right?
Yeah, that was absolutely fine.
Okay. And so do you have any allergies, Amanda?
No.
No. Okay. And do you have any other medical problems? Have you been told?
No.
Okay. Do you have any surgeries done in your tummy or down below?
Yeah, I had one appendix removal. That's it.
Okay. How was the recovery after that surgery?
Yeah, that was okay. That was all right.
Okay. Okay. And so are you well supported at home, Amanda?
Yeah. Everybody's around. Yeah.
Okay. You want someone to be with you now?
No, it's okay. I'll just do something. Yeah, I'm fine. Midwife is with me, that I'm comfortable with her.
Okay. Do you have any other family history of concern to discuss with me?
No.
Okay. So you are aware of your blood group?
Yeah, that's O positive.
Okay. You are aware of your weight to height ratio?
Yeah, that's 23.
Okay. Okay, Amanda. So, so the heart rate since the baby is doing good. And Amanda, would it be okay so that I can rapidly see your pregnancy handheld notes, and I would like to examine your pulse rate, blood pressure, and I would like to feel for your tummy, and there may be a need. I may need to do an internal examination for you. Is it okay with you?
Yeah, that's all right. Please, yeah.
Okay. Thank you, Amanda. Amanda, I could see the observations or so I'm having your CTG. I could confirm your identity, age, and NHS number, everything is right. And I could observe that your neck of the womb is completely open and the baby is coming down. And I could observe the baby as a heart raising at the moment is not happy.
What does that mean? That deliver him early. I mean, everything had been fine. I don't want to take any risk. What are the options? Please do that.
Yeah, please, Amanda. I'm right here to help you out, and I'll discuss you the options. And right now, this is the moment we need to deliver the baby as rapid as possible, because the baby is not happy inside. So that you very well know. And we have two options. We need to apply a kind of instruments, or we need to go for an emergency syringe section. Amanda, may I know about your thoughts at the moment?
I know, whatever you're comfortable with, whatever is good for the baby. I'm just ready for everything.
Okay, Amanda, that's I appreciate that because all we are here to make the baby very safe, and you also in safe place. And we observe the baby's head is a little bit lower down, and at the moment I would like to inform a consultant and the baby doctor as well, because there can be a chances we need to put some instrument. So we have two options. Either we call as a forceps, where we apply the forceps blades over the baby's head and we deliver the baby, or there can be an option of vacuum, we call as a suction cup. We apply the suction cup to the baby's head, and when you have your pain, we encourage you to push you down, and meanwhile we will just give a gentle traction down over so that the baby will be delivering. Okay,
I get that. Okay, so there's no chance that they would be missed. I mean, 100% the baby would be delivering.
Yeah, I'm coming to the point right now, Amanda, because the baby's head is a little bit it's not visible from outside, so there are more chances we need to go for a cup application with my consultant design. Because we are much concerned about the baby, because the baby's heart racing is not happy at the moment. In case if you are not able to successfully deliver the baby using the cup, we'll be attempting to deliver the baby at least 3 times. In case if it is not successful, the theatre is ready, and we'll be informing the theatre team along through the midwife coordinator, and there will be an emergency cesarean section for you. Okay, so this is for the benefit of the baby.
That's okay, but what if you go directly to the cesarean section? Why to waste time if there's some chances of failure?
Yeah, Amanda, that's a very concerning point. I can understand that. Having applying instrument right now, so we'll be shifting you to the theater. There can be a, we'll be giving anesthesia. If there is a more chances of the baby is delivering through the suction cup, that these timing could be reduced, and the baby will be immediately handed over to the pediatrician. There are also equal chances. We would like you to shift to the OT itself, and we'll be getting a consent from you, written consent from you there in the theater. And in case if the instrument happens to fail, we will we'll go for a cesarean section. Am I making clear?
Yeah, that's fine. And
okay,
may I know that whatever you're saying about this, all this green fluid and all, would that be like affecting my baby?
Yeah, the baby may be having some breathing difficulties after the birth, and the baby doctor will take care of you here, and we have called the senior person, and so he'll be taking care of the baby. And in case if this is going to be an emergency cesarean section, because you are well into your 2nd stage of labor and the surgery could be a little bit complex, we'll be having the seniors with us. Okay.
Yeah, I understand.
And yeah, Amanda, may I also check when did you have your last meals?
Yeah, I just took a little juice, maybe 2 hours back.
Okay. In case if you're preparing for an emergency cesarean section, we'll be giving you an antibiotics after ruling out the allergies, and we'll be giving some special medicine so that the juice should not trouble you during your anesthesia.
I understand, doctor. I understand. I'm all ready for everything, doctor. Please do something.
Yeah. Thank you, Amanda. Thank you for your time.
You made me clap for the station. Two in all domains, Ramya. Wonderful station. And the best thing in the station you did was that you examined me again. And that's why I said that, had you been taking the 6 centimeter forward in the station, that would have been such a big...
Sidra, 1 minute. I'll call my babies. You please clap in front of them. They were cheating me. 1 minute, please.
Yeah, please do that. Okay, very good station. Okay, let Ramya be back, then I'll be telling a wonderful station done. Now you people understand that why did I guide you people to examine again? There can be few students who do not examine her again.
Yeah, we are here.
Okay, hi baby, how are you doing? Hello, welcome to the mummy's station, huh? How did mummy do?
They didn't listen actually. They gave me a quiet room, but they, they were cheering me up, and
I can.
They asked me to pass this station.
Oh, wonderfully done. All domains 2 by 2. All domains. I've got few points I'll discuss with you, but none of the domain is even borderline, Ramya. Very well done. Very well done. Perfect station, sweetheart. Perfect station. The best thing was in the station, you started with stabilizing me with the pain. You confirmed the name and the age, and you encouraged me with this deep breaths and all these pains going on. You did ask about my concerns. You started the information gathering that this is the first pregnancy. You asked about the labor. How had this been going? You analyzed that the labor has been going well according to the dilatation I had been having since morning. You asked about the medical history, the surgical history, and you asked about the recovery after the appendicectomy. Blood group, BMI, family history, all was checked. That was all good points. So simply 2 by 2 in information gathering. When you did not ask me that when I was examined, I thought that you'll be missing out at examination, because when I was making this slide, I made the CTG, then I showed that you're inside the cubicle, and then I had put this recent examination. So if you would not have examined me, I would not have given you this paper. So if I would not have given you this paper, your management would have been revolving around 6 centimeter. And this is the mistake which I did in exam, not in exam, in the mock of the college. Now, what happened is that if you start doing at 6 centimeter, your management, of course, you cannot discuss about what is the situation at the moment. So you will discuss about everything which is going to be with meconium, a continuous CTG and observation. That's it. Yeah. So this is how, you know, the station goes in labor, and one of the station comes like this. Always mention, always ask in the history, may I know when was this last examination by the midwife when you were 6 centimeters dilated? I would have said that it was like 1.5 hours back. So you would have said that you're having constant pains, and with this green colored fluid, I would like to examine you again. So then you will analyze that, yes, in 10 centimeters, the story is changed now. And this is what happens in labor as well. I was happy that you examined me, and then you gave beautiful description of instrumental vaginal delivery versus cesarean section, consultant involvement, the baby doctor involvement, and anesthesia doctor involvement in the end. You asked about my meals. That was so practical that when you go with the emergency cesarean section. So you had, Ramya, you had your presence of mind in the station. You were not confused, and you were not, even if you were under stress, you had control over your stress. This is what I want in exam as well. Okay, so you were thinking about that, how the practical application of the knowledge, it goes in the station. One thing I would like to rephrase is that other than that, the baby has food inside, what I would say is that the baby has opened the bowels. Okay, so this is a little better phrase, because poo is fine, poo is fine, but it's a little casual term. Even in the strategy, if you have seen this video, the good candidate, they prefer that opening bowels is a better statement. This is what they prefer as well. Has somebody seen this? Yeah? Has somebody seen this video in the strategy as well? In which there's a meconium and you have to discuss about the types of the birth. So it's better that you say that I would like to tell you that the baby has opened the bowels, and that has turned the fluid around the baby green. Okay, this is how you have to speak. It's a better way of speaking. Then I would like to tell you that what this means is that at times this green fluid, gets thickened. When it gets into the baby breathing tubes, it might cause blockade and the breathing difficulty in the baby. For that, baby doctor has to accompany this delivery, and baby might require suction after the birth and assistance in breathing for first few hours or days. This is what I wanted you to speak for a meconium aspiration. Got that? Okay. If at all we don't deliver the baby early, there can be some unfortunate death of the baby as well. Therefore, we are going to expedite from this point onwards, and will deliver the baby earlier. So these two things I would have spoken, just to add on and tell the intensity. What is the difference between a normal clear liquor, and what is the difference between a meconium tinged liquor, and that too thick. Okay, so these two lines I have written that I would have added to your points, just to enhance the understanding of the patient. Okay. One more thing which I've spoken very clearly is that the station was +1. So rather than, you know, I said that, doctor, why are you wasting time on the forceps or the instrument? So go with the cesarean direct. So what I wanted to speak was, remember that according to the strategy labor module, +1 centimeter station at +1, it is always at +1, it is a theater instrumental birth. So I wanted you to speak that we are going to shift you to the theater for the instrumental birth, and if at all it gets failed, immediately the team would be ready to make a cut and deliver the baby through the tummy. That is cesarean section. Clear? So yes, yes. Make it very clear that we are not wasting time. In either of the cases, we will just give a try so that the surgery can be avoided. Very good, Archana. Well done. Archana only noted this point. Did anybody else note this point as well? That it has to be in theater because it's a mid-cavity forceps or a mid-cavity vacuum. It has to be in the theater. Very good. Communication with the patient was very good. I was very happy with all that. I was comfortable with both instrumental or the cesarean because my concern was the baby condition. So you took a very good history. All the history points were fine. I was happy with your information gathering, your tone as well, your empathy as well, and a perfect speed, Ramya, a perfect speed. I would say that you've worked a lot on your speed, and I'm really glad that this had really went well. The pros and cons of each, instrumental, vaginal delivery, and cesarean section, you told about both. and I was happy with both, so it was absolutely okay. What does meconium in labor mean? So you have to ensure that meconium in labor, it would be a continuous baby heartbeat check. We are going to have a plan of the birth through instrument. The benefits are that it's quick. The risks of the surgery complications, which are at the fully dilatation, damage to the structures, it is avoided, and it's a less hospital stay after delivery. However, there are chances of tear, and there can be some failed instrumental birth. There can be trauma to the baby as well. The other option is an emergency cesarean section at this point in time. So we don't have any risk of the perineal tear, and it's a safe delivery of the baby as well. Trauma to the baby is avoided as well. However, the complications of the surgery, damage to the surrounding structure, future cesarean section risks are always there, and more stay in the hospital, and more painful it is after the delivery, and the recovery time is prolonged as compared to the instrumental birth. So this is how I'm going to tell her the options at this point in time, whatever she's happy with. She was happy with both. So it is your decision in the end to shift her to the theater, apply the instrument, and if it's a state, it would be a cesarean section, because now we have a pathological CT. Claire? Yeah, Dipti? Okay, thank you very much. Wonderfully done, station. 2x2 in information gathering, 2x2 in communication with the patient, applied clinical knowledge and patient safety as well. A wonderfully empathetic tone in the station. The best part was that you did the examination. What I did in the college course was, I will just give you a hint which I did. The station was of preterm labor, and it was written that one line was that the patient is having pains, and the last line said that it is a patient with no cot availability. And I was so sure that she is 2 centimeter dilated at the moment, and it was written that she is having pain she's having labor pains. Now, I did not take the pain history as such that is it intermittent or is it going? That made me learn that I have to exclude abruption. Then I did not ask that when was this examination done of 2 centimeter. I was so sure that she's 2 centimeter, and I made all the arrangements, because that one line which said that there's no NICU bed availability. So I was so sure that they want me to judge in the intrauterine transfer. And taking that 2 centimeter forward, I did all the arrangements of corticosteroid, tocolysis, shifting to the intrauterine transfer, making the arrangement for the ambulance, shifting and talking in correspondence to the neonatologist team in the next hospital. All this I did. And in the end, Sir Andrew said that, would you like to know when was this examination done? I said, it's 2 centimeters, so we can do that. I mean, this is the safe time. He said, would you like to know when it was done? And then he said that, had you been asking me that when was it performed, when was it was done, she is 7-8 centimeter at the moment. Would you do the IUT? I said, no, I would not do the intrauterine transfer. Now I would do the extrauterine transfer. And that was the station all about. So that day, and literally I had tears. I was so nervous at that time. And I still remember his face telling me, always remember, Ali, that you have to examine the patient if examination had been a little earlier, or inquire the patient. And that day, and I always tell my students, please don't forget, because recent examination can change your management. Did you people understand? So I was happy that I gathered all these points, like, you know, it was 21 days before the exam. Yeah. So you absorb those things. You learn from your discussions. Am I clear? Dipti, Ramya, Sujata, Archana, Dr. Sabiha, all of you, am I clear? That what is the difference between that? Okay. So that changed the station. I did the entire station. And, you know, 3 times I remember that the role player mimicked labor pain. And I was like, oh my God, why is she doing again and again? I have to move forward and I have to tell a lot of the intrauterine transfer. And why was she doing the pains again and again? Like, please examine me. I'm not 2 centimeter at the moment. You people get my point. But at times when we don't have a broader horizon, we don't examine the patient because we don't think in that way. We just go in our own, a focused manner, whatever our brain is thinking at that time. So always keep your labor module, always keep that one question in the history that is now in my template. And I always teach the students that always ask them, may I know when was this examination done? So speaking one line like Ramya did, that I would like to examine you just to see that what is the state of the neck of the womb at the moment. If there would be some change, examination would be provided to you. If not, that's okay. Go with the same flow. So if they don't interrupt at that time, it's okay. You've spoken your line, your job is done. You're safe now. So at least go with the older thing. Am I clear, everyone? Yeah, yes, kudos, Ramya, Dr. Sujata, well done. So this is how the outline goes. Introduction, agenda, offer the pain relief, yeah, focused information gathering. Whatever she wants first, do that. I was happy with both. So yes, she was right here to take care of me. So this is how the outline goes. Dr. Sabia, thank you very much, Dua. Dr. Sabia, you were asking about the station yesterday in the mini group, that how the instrumental vaginal delivery is there. So this is how it is. Am I clear now?
Yeah, you are very, very much clear.
Thank you very much, my dear. Thank you. So this is how the station goes. Thank you very much, Ramya, for building up my hemoglobin. I'm sure I have gained 1 gram per deciliter now. Thank you very much. Thank you. All right. So after this wonderful station, we are having the third station of the day. And if I'm not wrong, we have got Divya. Hi, Divya.
Yes. Hi, Dr.
Hello. How are you doing?
Fine, I guess.
How many cakes did you bake in the last 2 weeks?
None. Absolutely none. None.
Routine going. How is the COVID situation, Divya? The first.
It's really bad, Dr.
Oh,
even today, one of the I an emergency is not fully symptomatic.
Oh, okay. So all the PP is being practiced?
Yes. As much as we can. The problem is with the doffing. Donning is really.
Thank you, Ramya. Thank you very much, my dear. Just listen to the recording whenever you have time. Thank you, Ramya, sweetheart. Go for the call. That's okay. Yeah, Divya, what were you saying? Sorry?
Doffing is difficult, Dr. Sisra. It's really difficult to doff without contaminating.
I can understand. It's very tough. But the thing
but
is,
otherwise, it's okay. I'm sort of getting used to the fact that it's going to be.
I know, Divya, the worst thing is actually the first phase didn't end and the second has come. So, that break didn't come in India.
Yes.
That is something which was concerning. And many of the students, they were worried about that. Many students themselves, many in the family members, they got affected. So lots of prayers. I hope things they get settled, my dear, sooner. So let's do the station. It's going to be a little...
Personally, our group has been completely off the radar.
Yes.
I am to be blamed.
Yeah, actually, somebody has to take the lead. Somebody has to encourage. 1 or 2 people can be busy one day, but the entire group not meeting would not be a good idea. Okay, so if one person is not there in one day, that's okay. So he or she looks at those who are doing and gets encouraged. Oh my God, I'm missing out at something. So if everybody gets silent, then it's a problem, Divya. So this 2 weeks time, you all were very silent. So let's hope.
I'm glad you're not putting up graphs anymore.
Yeah, because now I cannot do that for 2 weeks because you're taking breaks as well.
Dr. Sidra, you also very silent these 2 weeks. You did not give us slap. Divya is right. You didn't give any slap to us.
Actually, 9th was MRCPI exam. And
okay.
So was so much into those, and now 27th is part 2 exam. Daily I have some booster sessions with them, and all are crying, and it's such a difficult thing which Irish College did, Dr. Sabia. 2 days before exam, they cancelled 10 students registration and exam. So just 2 days before exam. Online it was from home. So lots of things had been going on in other exams as well. But otherwise, I did know about your group because few of the people, they were having some illnesses and few were having them shiftings, and you had kids around. So I knew all the commitments. Therefore, I was like, okay, take a breather. And about Divya's group, I was in touch silently with a few of the members. However, I'm sure now Harshipa is going to take lead. Harshipa, I give you the stick. Take Sidra's stick and please apply that on each and every one on group D, okay? Yeah, Harshaba? So take Sidra's stick and do that, okay? Right, all right. So let's move to...
Harshiba's there, Dr. Sidra. I don't think she's there.
Yeah, so she'll be listening to the recording and she'll take the stick.
She usually is there, but this week even she is sort of missing.
Yeah, I'm sure she'll be joining. Tag her, somebody tag Harshiba in the main group that we are missing her. Please join in.
I'm here, ma'am. You can't hear me. I'm here.
That's perfect.
Harshiba's
Harshiba doesn't miss the
Session.
sessions. I know she's my golden star student, you know. She never misses.
Ma'am, I've been here only. I've been listening from the beginning.
Thank you, Sweera. Thank you. Okay, so let's do the 2 minutes time for the Divya and let's see. Yes. So stick, I've handed over to Harshiba for group D and I've handed over to Sarvat for group A, please. And please apply that on Dr. Sabia as well, okay? Yeah. Please become a stick master. Okay, so 2 minutes are starting. Go ahead, Divya.
Okay. I'm not able to see anything on the screen.
I've changed that. Probably a little delay. See that? Is it changed?
Yes.
Okay. Start, please.
Hello, I'm Dr. Divya Prakash. I'm your registrar with you today. How are you? May I confirm your name and age, please?
Start that again, Divya. The voice was disrupting.
Hello, I'm Dr. Divya Prakash. I'm the... Can you hear me?
Yes.
Hello?
Yes, now voice is
Hello?
okay. Yeah. Keep the volume in the same bit, okay? Yes, please start.
Okay, I'm Dr. Yes. I'm Dr. Divya Prakash. I'm one of the doctors in the labor room today. May I confirm your name and age, please?
Hi, doctor. Doctor, I'm Lena John. I'm 21 years.
All right, Lena. So the midwife just gave me a call because she's seen you before. And she told me that you're in labor. Am I right?
Yeah, she just checked me and she said that yes, the neck of the womb is getting dilated.
All right. So before I can proceed with you, can I ask you a few questions to know more about you?
That's okay, yeah.
So, Lena, is this your first pregnancy? Can you tell me more about this pregnancy?
Pregnancy had been absolutely fine, no problem at all, doctor. I had all my regular checkups, all ultrasounds. I just came 2 weeks back as well. The baby was fine.
Okay. So how far along in the pregnancy are you now?
I think it's around, I'm reaching my 38 weeks, 37, 38 weeks, yeah.
All right. And since when have you been having the pains?
It's been around 5 hours. I'm having discomfort. After every 7 to 8 minutes, I feel that there are like 30 seconds of some tightening in my lower tummy.
Has there been any bleeding down below?
Not exactly, but I just passed a little discharge. That was, I feel that it was blood tinged.
Have you had any watery discharge from your vagina, like fluid?
No, no.
No. Are you able to perceive your baby movements?
Yeah, the baby movements are absolutely fine. Lisa's doing great.
Oh, wonderful, wonderful. I see that you've named her, Lena.
Yeah.
So, Lena, is this your first pregnancy?
Yeah, I told you, yes.
All right. Is there anything else that you've been visiting a GP regularly for? Any other illnesses running in your
I'm
family?
absolutely fine.
You're absolutely fine. Wonderful. So, from your notes, Lena, so when were you examined last?
Yeah, it's just like 15 minutes back.
And how are your contractions going now? Is it very painful? Is it
I
sustained?
just
Or is
had it, I think 10 minutes back I had one. Oh,
What?
doctor, they're coming again. Oh,
Oh, all right. Yes.
oh,
Good, 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 good. Just keep breathing out.
oh,
Yes.
oh.
You're doing fine, Lena.
Yes, doctor, please, yeah.
So, Lena, I've been informed by the midwife that, Lena, have you had any ultrasounds recently?
I just had it like maybe at 34, 35 weeks, yeah.
And where was there anything that was of significance in that ultrasound? Were you informed
Nothing. They
about
said the baby is
results?
absolutely fine. No.
Oh, okay, Lena, so this happens once in a while. And what you have right now is called a breech presentation. That is, the baby's bottom is down below in your womb rather than the head.
Oh, how is it possible? I mean,
Yes,
since my last checkup like 2 weeks back, everything was fine. The baby was like head first.
head first. So usually what happens is earlier in the pregnancy, while the baby is smaller and it is still growing, the baby keeps moving around in your womb. But somewhere around 36 weeks, as you reach your last month of pregnancy, the baby begins to descend and fixes in one of the positions. And your baby, Lisa, has decided to fix in the
This
breech
is what I'm
position.
telling you, doctor, that last week the baby was head first.
Your baby was head first.
Yeah.
Was the ultrasound normal?
I mean, I came to the clinic and they said that yes, everything is fine and you're ready to go into the labor maybe any time.
Oh, but your baby's gone into the other position. It happens very rarely. Around 3 to 4 women in 100 have this kind of a presentation.
Very strange.
And the thing is, your baby's bottom is below. I know, I know. There are a few things that might cause this, but so far your pregnancy has been perfectly fine, so I wouldn't be very worried. Has there been any increased fluid in your belly that you've been informed about recently or
Nothing
before?
at all. No,
Absolutely
no,
not.
no.
All right. That's all right, Lena. Around 3 in 100 women have this kind of a presentation. And right now, the baby is going down in your womb further and further down with the bottom below.
Okay, so what to do
Are you
now?
very? So first, before proceeding, I would like to confirm that it is a breech presentation. I would like to do a quick ultrasound to see the position of the baby's head and the baby's bum and to see where the legs are. Is that okay?
Yeah, that's okay. Ultrasound is just done like maybe 20, 25 minutes back.
All right. And what did they tell you?
They didn't tell me any report.
All right. So the ultrasound confirms your reports. I have them here. And it says that the baby is in breech and the liquor is good and your baby is moving very well. All right. However, what bothers me is that your womb is opening up and your baby is descending further and further down. So in a position like this, Lena, there are two things that we can do. All right.
Yeah,
One
what?
is to
Sorry?
proceed.
Doctor,
There are
if you
two
keep
things that
Yeah, mic a little closer.
All right. When you present like this, there are only two things that we can do, Lena.
Mm-hmm.
And one of it is if you had presented a little earlier, as in before your uterus is opened up or your baby has descended completely down, we could have maybe turned the baby around. All right. But now that your pains are coming really close together, we have two options. One is to proceed with a vaginal breech delivery, and the other one is to go ahead with a breech cesarean delivery. Can you understand, Lena?
Yeah, I can. What is better for me?
What, Lena?
What is better for me?
I would suggest that you go in for I'll first list out the positives of both, all right? So with the breech cesarean section, the best thing is that we can be assured that your baby is going to be safe and there are less morbidities for you. However, it means increased risk in your next delivery. It means that your placenta might get abnormally adherent to your uterus in the next pregnancy, and you might need another cesarean section for your next pregnancy. All right?
Mm-hmm.
But the problem, and this is about cesarean section. If you choose to have a cesarean section, then we can do that as soon as possible. However, with the vaginal breech birth, the thing is, you can choose to have it. You will need to be. The problem with the vaginal breech delivery is there is a small chance that you might lose the baby during the process of birth, and immediately afterwards as well. There are some serious short-term complications for your baby. However, in the long term, it does not affect your baby. All right?
Okay. Okay. So, what do you think? I mean, there must be like something which you should be doing to your patients. What do you people suggest? Definitely, I was, because the baby was head first, and I always wanted Lisa to be born normally. So this is what I was knowing about it.
Yes. So from what I can see, a baby's head is at that point where it is beyond a point where I'm comfortable doing an external cephalic version where the baby can be turned around. All right.
Okay.
I would suggest you go in for a cesarean section because right now it is the safest option. Your membranes, that is your womb has your membranes have not opened up, your baby has not lost any liquid yet, and the baby is fine. We usually don't go in for breech vaginal delivery in our center.
Okay, right. Can I just discuss with my partner? Do I have a little time?
Yes, definitely, Alina. But I'll give you a minute or two. You can have a little chat with your partner.
Mm-hmm. That's okay. So I'll just get back to you after discussing with him.
Something bothering you? Is there something else that you'd like to ask?
No, that's it. I'll just discuss with him and I'll get back to you that what do I want.
All right.
Okay. Thank you, doctor. Thank you. All right. So how was the station?
Dr. Sidra, don't scold me. This is the second time I'm bombing a labor station. How was it? I was lost for words.
Yeah, you were not in practice today. You were not in form today.
At all.
Yeah,
At
even
all.
in the information gathering, this was not like how Divya talks. Even in communication with the patient, it was not like how Divya talks. Even in the applied clinical knowledge, this was not like
everything. I know.
In all the domains, and
Everything.
patient safety, I cannot pass you at all. Okay, I'll give you borderline in information gathering, though it was not at all structured today. I will give you one in applied clinical knowledge as well, just to mention, but still, in fact, less than one, because few of the points I disagree. Will discuss with you. It was not organized the way you present. It was not you actually today. And communication with the patient, you have this quality of communicating in a wonderful way. But today you were very shaky today, starting from the beginning. It was a very
My family is
shaky
banging on my door to open the room. My whole family is
can
also
understand.
back.
I can understand. Guys, what is that thing for which I
Meet is
cannot?
tomorrow. My sister's writing.
Ah, I get that. Okay.
Clinical knowledge.
There's one thing for
Clinical
which
knowledge, Dr. Sidra.
there's one thing for which I cannot pass the patient's safety. That what is that one thing?
Ma'am, it's incident reporting, undiagnosed breaching labor.
Very well done. Very well done. I was saying again and again that since last week it was like a phallic, and you were trying to defend that. Okay, it happens that baby turns. You have to say that clearly. We will look into the matter as to why it was missed. Undiagnosed breach is an incident reporting. That to a booked patient. Yeah, a wonderfully booked patient coming after every 1 to 2 weeks time. It's a trigger for incident reporting. Did you all get that? How many out of you knew that it is going to be an incident reporting? Tell me honestly, other than Archana. Tell me honestly, how many of you knew that it's going to be an incident reporting? Very good, Bindu. Well done. Very good, Dipti. Well done. Dr. Sabia knew that? Okay, great. Fauziya knew that? That's perfect. Okay, no problem, Dr. Suchata. Now you'll not forget. So remember that undiagnosed breach is a trigger for the incident reporting. Don't forget that. Starting, Divya, when you entered into the cubicle, yes, it was, you confirmed the name. You said that, yes, I'm Divya. No need to take full name, Divya. I've told this earlier as well. Only Divya is fine, because when you say Divya Prakash, it starts taking your time. Every unnecessary word has to be taken off, right? Then information gathering you started, but it was very shaky start about the pains you had to take. You did ask about the leak. That was all right. When I said that it's Lisa, do communicate with the word Lisa at least once. Use the name. This is what I told you in maternal medicine and antenatal care as well, okay? And then medical history you did ask. Other than that, no history was asked. Surgical history was not asked. Family history was not asked. Allergy was not asked. All these things which I expect that in information gathering has to be there. Then you did some sort of a defensive explanation of the breach. That the breach, first you said that at 36 weeks they get fixed. And then you said that it can rarely turn even after 36 weeks. That's why initially you were cephalic and now you're breech. So I told you that since last week I got my checkup and it was a baby head first. So at this point, you're being defensive makes you go towards fail, because you have to accept that something wrong has happened. However, now we are here to deal with the situation. As to why it was missed, I'm going to discuss with you, okay? So then you did ask about the ultrasound last one. I did tell you that everything was fine. From the points to improve from the beginning, avoid the word Prakash. Only Divya is fine because it starts taking your time, my dear. Then use the word, you have to take the full history of surgical, family, allergy, BMI, because that affects your management plan. And also, I would ask about did anybody talk to you about the birth weight of the baby? So I would ask specifically just to fit in her to the criteria of breech vaginal delivery. Now, when I was having pains, what do you people think? That breech vaginal delivery, should you encourage the pain? You're doing good. It's fine. The same rule you would apply of the preterm labor here, because breech vaginal delivery is never appreciated. So the rule of the preterm birth would be taken here. What you would say is that, do you need any painkiller? All right, please take your pains and let me know when it fades away. That's it. Become silent. Don't appreciate a breech labor pain. Same as that of preterm, because breech vaginal delivery is not evidence-based. It is not recommended. Only when she comes into the advanced labor, we suggest that. That's it. Otherwise, it is not recommended as per the Green Top guideline. So apply the same rule of the preterm. Stay silent, ask about the pain relief, and tell her that I'm right here. Please take your pains and let me know when they go fade away. Okay? Don't say, yeah, you're doing good. Yeah, well done. So that means that you're encouraging the normal birth.
Normal.
Okay? Yeah?
But
so
Dr. Sidra, shouldn't we tell them to take a deep breath and relax?
No.
No.
You just
Take
say,
a
this is
painkiller
what you
and
say.
let me know when
These
the
are
pain
again
goes
the encouraging words. Okay. You said that, do you
away.
require any painkiller? Yeah, please take your pains. I'm right here to talk to you. Just let me know when it's over. That's it. Okay. So this is what you have to do in a preterm birth and in a breech labor. Now, when I would come to this, I will tell her that what does ultrasound done? I told you that it's done just 30 minutes back. No need to repeat the ultrasound, Divya. Why? It's undermining of your colleague. The ultrasound shows breech. Abdominal examination, vaginal examination shows breech. I told you specifically that it's done just like 15 minutes back. That's all right. Okay, that's all right. Now, the third thing in applied clinical knowledge, which I don't agree with. What is the cutoff for external cephalic version in early labor, please? Anyone? Why can external cephalic version not be tried here? The chances of failure are definitely there, but what makes you decide that it cannot
Breech
be
is at
done?
the level of spines.
Beat.
So you disengage.
Yeah.
There's a way in which you make a cup on the buttocks and you make an unengaged by just pulling up, pushing up. Okay, the prerequisites are fulfilled. The membrane intact. Had it been membranes absent, I would have spoken what you have spoken to me. Had it been more than 4 centimeter established labor, then you can't do. Remember, early labor, we perform external cephalic version. Less than 4 centimeter, membranes should be intact. No matter station is engaged, you make a cup and you try to disengage. These
So
two
even at zero,
prerequisites
we
are
do
there.
ECV, Dr. Sidra.
Sorry?
So even at like station 0, where the head is, where the
Yeah, we can do
buttock
that.
is at spine, we do an ECV.
Yes, we do ECV provided membranes are intact, provided she's less than 4 centimeter. However, you give this hint to her that the chances of failure of the procedure, turning the baby through tummy in head first, the failure risks are more because you're into labor. However, we are going to give an attempt to avoid the cesarean section. Get my point?
Yes.
Yeah. And in history, yes, I wanted to ask that one anomaly scan, I would ask specifically that was your mid-pregnancy scan done and was it normal? Why? Because they're associated with the anomalies. I'll ask in the history, not now, in the history. Okay, right? And we should tell the patient, Nadra has a question, you need to take ultrasound to take the weight and the extended neck. No, what you're going to say is that, did somebody talk to you about baby's weight? That's ultrasound at the moment would only be done if she insists for a vaginal delivery. At the moment, she's not insisting. She's saying whatever is best for me. Nadra, you get my point? If she's adamant to have a vaginal delivery, then you would say, we will perform an ultrasound just to see that all the prerequisites and the baby being delivered vaginally would be safe. Then would that point be coming, Nadra? Not now. Because right now, she's ready for everything. She just needs the pros and cons of all 3 options. Okay? Yeah? Bindu has a question that, ma'am, if no ultrasound done after anomaly scan, should we repeat a scan? Yeah, so this breach is confirmed on a scan. So if it's only examination, then definitely you will do a scan. Yes, Bindu, if it's only an examination, my dear, then you would definitely do a scan prior to telling her confirmation through scan is must. Okay? Very good, well done. Now, where in the management plan things they went wrong? In communication with the patients and the relative, don't speak during labor pain. I was happy with that, but don't encourage, okay? Don't encourage. History of the presenting illness was fine. Asked about the labor history, the obstetric, the gynae. However, the family surgical drugs allergies were missed. BMI was missed. Don't do that because that's important. Now, patient safety is that pros and cons you have to tell of each. Whatever she's happy with, it's okay. If she goes for a vaginal delivery, a continuous CTG in expert hands, it would be done. This part should not be missed. If you miss incident reporting, that means that you are being defensive for the patient. This can happen. This should not happen. A booked breech patient should not be missed. Please don't miss this point. Otherwise, patient safety would be failing. Now, applied clinical knowledge is ECV versus breech vaginal delivery versus lower segment cesarean section. I would tell her that according to your examination and the ultrasound performed, the baby is bottom down. I would like to tell you that we've got certain options for that. Either we can turn the baby through the tummy, a breech vaginal delivery, or a cesarean section. May I know, do you have any concerns regarding each? So if she gives you some sort of a clue that she wants this, it's okay. If she is comfortable with everything, you will start with the cesarean section. Say that I was asking again and again, what is suggested? What do you people do? So what I wanted you to speak is that the evidence suggests that the cesarean section is safe for the bottom down babies. And there are some complications of the surgery and the anesthesia or the future surgery risk as well, prolonged hospital stay as well. However, it is suggested that to deliver the bottom down baby through the tummy because it is safe for the baby rather than going into labor. However, at this point in time, we can try that we turn the baby through the tummy. The risks would be that there can be some failure of the procedure because you're already in labor. However, the benefit would be that cesarean section would be avoided and less complications are there. At times during this procedure, the afterbirth can get separated early and can be an emergency cesarean section requirement or the failure of the procedure as well. Are you with me, Lena? Few of the patients, they desire to have a vaginal delivery. I would like to tell you that a continuous baby heartbeat monitoring would be done in that case. Yes, there are some benefits to that. The surgery complications, they're avoided. It's a lesser hospital stay. However, it is suggested to avoid the vaginal delivery because the risks to the baby during labor and after the birth is more as well. The head at times get trapped at the neck of the womb, and you might have to give some cuts in the neck of the womb to deliver the baby's head. You make up your mind in what of the options you're comfortable with. So after telling all this, if he says, I'm ready for everything. So what you would suggest is, at the moment, my consultant is on the way. We are going to try to turn the baby through the tummy. You're successful. We'll proceed with the normal labor. If at all there's some complication or a failed procedure, we'll decide for the cesarean section. Would that be okay? Now your applied clinical knowledge and your patient safety would do fine. Am I clear? Remember that the evidence-based applied clinical knowledge is cesarean section is recommended for the breech unless they're in advanced labor. Okay, that the perinatal morbidity and mortality is more to the cesarean section in advanced labor. They can go with the labor. Otherwise, always recommend a cesarean section. Am I clear, everyone, that how you're going to proceed with the station? Yeah, what are those things which you're going to speak in the station? Always ask her, take the patient along. Don't just dictate. And Divya, I would like to rephrase my one sentence, my dear. You said that because it's a bottom down baby, I will suggest cesarean section. This I will suggest shows a little bias in the terminology. What you have to speak is that it is suggested by the evidence that cesarean section is safe for a bottom down baby to be delivered. So do you see the difference in the statement, my dear? Okay, the same thing I'm saying. Yes, I am suggesting cesarean section, but I'm saying it in a manner that what is recommended by the evidence. Okay, because when I was asking again and again, you said that I suggest that you undergo a cesarean section. That seems to me that you have some inclination towards the cesarean section. Probably you don't want my continuous labor monitoring. Yeah, you have to say it is suggested for these women that it is safe for the baby to be delivered by cesarean section. Are you there, Divya? Claire? You can write in the chat box, my dear. I can understand there's a little commitment at home. Yeah. Claire, sweetheart? Okay. So these were a few points I wanted you to improve. I'm sure you will do good once you'll come back to the practice zone.
I am going to send this to you, record it and send it.
Oh, that's wonderful. Yes, I would love to do that so that I can understand that you've gathered up the things well.
Yes.
See, none of us is a perfect person. I know my students, their basal level. When they're improving from their basal level, yes, I get encouraged. I know that you have a tendency to speak beautifully. You have a tendency to have a command and composed even under nervousness. I've listened to you earlier as well. But remember, any person who would be away from practice would definitely lose the confidence and the flow. The flow of the words, it comes with your continuity of your spoken. It comes with your continuity of your communication.
Yes.
It comes
Yes.
continuity with your practice.
Because today, Dr. Sidra, I had been to breach the GTG and the PIL, and I was very sure that I can do this, but I haven't been practicing at all.
I understand. So
At
reading
all. And
does
I
matter.
struggled so much.
I
It's so
understand, dear.
difficult.
So it's
Though I knew everything and I knew what to
but you
say,
were
what
you
to
were
do.
struggling to put into words. I could guess that.
Yes.
Yeah,
Very
I
difficult.
understand. I understand. I would give you my example. See, students, they contact me and they say that, how do you have a good flow? How do you speak in just like, it seems that everything is pre-planned. I would tell you guys that it's been like 3 years now, right? And if I myself take my first session of part 2, I would see that if what I do now is way too better. I compare myself. Whenever you people are into practice, your every passing day is better than previous one. I was contacted by respected Dr. Rada for her free course she wanted me to take for her Arabic students, right? She requested, because some students were requesting that I should take a session from there. And it was around 700 people in the live session. I was having difficulty in managing. I shared with you guys the link as well. I was having difficulty in managing. And after that, you people won't believe my part 2 strength. Around 60 students, they registered in just 5 days' time. And I was astonished. And I was talking to Dr. Heather at that time, and I was telling him that, no matter, I don't understand this point that the level and the groups and the point we are having in this part 2 or part 3 MRCOG at the moment, because everybody is trying to be online. You need to excel because you need to be better than others. So that means that even me myself, I have to improve every other day. Okay. So when I, as a mentor, I'm putting in an effort to be better than all, right? So I have to excel in that field. That means that you as a student have competition, a lot of competition. It is not that you people practice and you say that now we know everything and after 2 months we would be the same. 1 hour of practicing, please take out. If you can't take 1 hour, take 30 minutes and do a station. But please take out 30 minutes. In 24 hours, taking out 30 minutes is not difficult. I'll give you an example of one of my students. She's in the June batch. She's having 4 consecutive nights duties, and she's not going home because of some COVID duties. And she daily puts in a message that, Sidra, I'm in labor ward duty, and with my midwife, in my midwife, I am practicing 1 station daily. She becomes my role player. So this is how you have to accommodate yourself into your daily routine. She is not having any books, nothing. She takes a station from any of the email of any past station, and she does that with her midwife. And now her midwife, she says that she's become such a good role player, whosoever is with her on duty. So I would like to tell you that you have to take your own circumstances. Maybe whatever suits Bindu doesn't suit Divya. Maybe what suits Divya doesn't suit Dr. Sabiha. But you have to understand that 30 minutes you have to practice 1 station. If you don't do that, your practice gets faded away, which we don't want, right? So am I clear, everyone? Group B, I'm talking to you guys as well. Dua, Nadra, yeah? So I know that exam, you people know that it's not there, but 30 minutes, please. 1 station only. Speak up 1 station, speak up the information gathering. Like today, Divya was missing out at information gathering as well. So that means that does she not know the questions of the information gathering? She does know the questions, but the only thing is that it was not coming on her mind. The flow was not there. You get my point, Fawzia? The reason is not that she doesn't know the question. The reason is that the flow is not coming. The continuity is not coming. All right, very good, well done. So please keep going like that so that we improve and we move forward. Very good, well done. So remember that the recommended option at the Green Top guideline is cesarean section. So it's going to be introduction agenda. If she's having pain, give her pain relief. Do not encourage as in preterm labor. Just stay silent, offer her pain relief. and tell her about the breech vaginal delivery concerns, ECV, and the cesarean section as well. All right. Thank you very much. Thank you, Dr. Sabia. Thank you. And if you are here, you're not here, Athiya, I can understand that you must be on duty today, Saturday. So when you listen to the recording, I'm talking to you as well. Please gear up for Group A as well. Okay. Thank you very much. Today, up till now, only Ramya is the one, and she's having so tough duties, I will tell you, and you can compare. Do you remember her bullet train station? Ramya's bullet train station, the first one? And do you compare her last station and this station? She is taking pain. She messages me that, Sidra, I just want to clear at any cost. I'm not leaving my stem in a building. I'm doing 30 minutes at all. And she is the one who is bringing up all Group C together. She and Dr. Sujata, I know, that gathering up everyone together. So please do that. Very good. Well done. So this is the capability is in all of my students. It's only who's working for it. See, I can give you lines. You can mimic my tone. You can copy the way I tell you that this is how you have to be organized. However, I wish I could speak at your place. So this is one thing which I can't do. So you have to copy that and you have to speak for me. This is what my requirement is. So do one station and just speak for me. This is what you have to do. Okay? So this one thing, I'm giving everything in platter. I just want that you just speak in like the way you have to do that. And I'm sure things would be perfect. Okay? Very well done. Very good. Yes, she was very good. Dr. Bindu, she's really working hard on all these elements. Yeah. Exactly, Jyoti. Today she was perfect. I mean, I was so comfortable talking to her. Every element in the station was perfect. It was like a very good scoring station today. Very good, Divya. That's like my girl. Well done. Don't make it a headache, Divya. Make it like 30 minutes. Okay, who's doing a station? Correct her. For example, like Archana would have listened to this station. She would have corrected that incident report has to be done. So when you discuss the points, you learn from each other. Okay? Very well done.
Yes.
Okay. Thank you very much, Divya. Thank you. So
thank you, Dr. Sudra.
Thank you, sweetheart, for making an attempt despite being very.
I'm gonna go to my room and start crying now. I'm so down
no tears at all. This is not
tears.
Yeah, you will pass, my dear. I'm 100% with you guys. The moment exam date would be announced, you all would be perfect. Don't worry at all. Okay? Don't worry at all. Okay. So let's go with the station number 4. And who is my friend now? Okay, so I've got Archana here. Archana, thank you very much for volunteering for Abir, my dear. How are you?
Yes, ma'am. Fine.
Good evening.
Actually, busy in last week, but fine now.
Sorry, what?
Actually, very busy in last 2 weeks, but fine now.
So, the hospital routine has started?
Yes, ma'am. Yes.
Oh, so you've started gynecology as well, huh? The elective surgeries?
Yes.
Oh,
After doing COVID test and all the things.
I understand. Yeah, please do that. But I think and husband is back in the hospital or he's still away? I mean, he's there to support?
Yes, ma'am. He is not supporting me at all at my hospital.
So he's doing his own work. I can understand. No problem.
Yes.
Okay, no problem, my dear. It's better that you do it now rather than, last 2 months I would require from you that you take a little off from the hospital when the exam date.
Yes, I'm going to do it.
Yeah,
yes,
thank you very much. Thank you, my dear. Okay, so let's start with the station number 4. And 2 minutes, they start now. Please go ahead.
Okay, next. Okay, next. Ma'am, next slide.
Yes, I've changed that, dear. GP letter.
No, not visible on my screen.
Okay, no problem. Take your time.
Yeah.
Thank you.
Next.
அது என்னது சாம்பாரா வீட்ல சாப்பிட்டாச்சுல ஐயோ சிக்கன் கேட்பானா எனக்கும் தெரியாது
Okay. Show me the second slide.
Sure.
Okay.
Yes, Archana.
Okay. Hello, I'm Dr. Archana, one of the doctor in antenatal clinic today. May I confirm your name and age?
Hi, doctor. Doctor, I'm Monica Johnson. I have 39 years.
How can I address you?
Yeah, Monica is all right.
Actually, Monica, my consultant is not here due to some unavoidable reason. Is it okay? I can continue the consultation?
Yeah, that's fine. Thank you, doctor.
Okay, thank you, Monica, for it. Monica, from your GP letter, I gathered that you are in your first pregnancy and carrying a twin baby. And here to discuss your birth plan. Is it correct?
Yeah. Exactly, doctor. Actually, I discussed with midwife and I plan to have a home birth. So she said that I should talk to you about that.
Okay, that's good. Yes, surely in next few minutes we will discuss all possible options and address all your concerns and formulate mutually agreed and safe plans. How it sounds?
Yeah, that's perfect. Yeah.
Monica, as we are meeting for the first time, can I know more about you?
That's okay. Yeah.
Tell me, how is pregnancy so far, Monica?
The pregnancy is going perfect. Lisa and John both are having very good movements as well. I started off with my all early investigations. They were fine. I just had a scan last week as well, and it has shown that both their weights are within the normal limit. And Lisa is first baby, and she is head first, doctor.
Okay. Yes, I had just checked your UHG. It's normal. Good. Are you taking pregnancy vitamins, Monica?
Yeah, I'm taking some tonics. Yeah.
And do you know your blood group?
Yeah, that's O positive, doctor.
Any reservation for blood transfusion if required, Monica?
Not exactly, no, doctor.
May I know your height to weight ratio?
Yeah, that's fine. That's 23.
And does anyone told about the afterbirth? Is it shared one or a different one?
In the beginning, they said that they're separate. They've got separate bags and separate afterbirth as well.
Okay. Monica, any medical illness for which you are seeking help with your GP?
I'm absolutely fine, doctor.
Any history of allergy?
Not exactly, no.
Okay. Any illness in family which you want to share with me?
No, doctor.
Any history of surgery on your tummy or below the arm?
No, doctor.
Monica, do you smoke, taking alcohol, and pardon me to ask about recreational drugs?
No, doctor, I'm not doing that in the pregnancy.
Good to know that. What do you do for living, Monica?
Yeah, I work as a teacher.
And how is support at home?
Yeah, support is perfect. My partner is really anxious to have the babies, and they've done all the shops for the baby, their costumes and everything.
Oh, so you're a happy couple, right?
Thank you.
And how had you been feeling in last few months?
That's perfect. I'm really happy to have the babies, yeah.
Monica, can I examine you in presence of chaperone?
That's okay.
Yes, I will check your blood pressure, temperature, your heart rate, respiration, and I will examine your tummy to see how John and Lisa is doing.
That's okay.
Yes, it's good, Monica. And now I would just like to tell you at the very beginning that It's your choice where, how, and when you want to deliver, and me and my team is here to support your decisions.
That's
But
perfect. Thank you. Thank you.
may I know concern behind choosing home birth, Monica?
Doctor, there are two reasons. Actually, one of my neighbors, she had a delivery in the hospital. She was also having twins. Somehow, first baby was delivered, but the second got stuck up, and they tried to give more pains. Then instrument was applied, and that was failed, and taken to the theater. Then cesarean was done. Then she had some complication, infection. So she stayed for like 15, 20 days in the hospital. That made me so scared. So this is one element I don't want. And secondarily, I would like to take labor at home because I want that environment. Because I'm happy with my partner around and all.
Okay, Monica, sorry to hear about your neighbor, what happened to her, but it doesn't not necessarily mean that same thing happened with you also, as every individual is different with one another. I will discuss all the possible options, and I appreciate that you are planning for home birth. It's away from all the buzz of machine, less chances of infection, surrounded by familiar people with lovely support of your partner, and of course with your favorite music. That lovely choice, Monica, to get delivered at home. But I have few concerns. Can I proceed?
Okay, yeah.
See, Monica, considering your age and it's your first pregnancy, and that with twin babies, there are high chances or there are certain possible complication can happen. Are you here? Are you listening?
Yeah.
There are high chances of cesarean section at this age also, and due to after the age of 35, and there can be the labor can be prolonged. And also with twin babies, women are at higher risk of cesarean section compared to the single babies. I know you want John and Lisa to be safe and healthy.
Yeah, definitely yes. So what cannot be done at home? I mean, what are those things which I require hospital birth?
Yes. I'm commenting on that also. In labor, we want to do continuous heartbeat monitoring of John and Lisa during labor, and I'm afraid which is not possible at home. Even if everything goes fine in labor, many times first baby, Lisa is first, right?
Yeah.
She can get delivered, but there are chances that second baby may change the position, or we may require some manipulation through tummy or some instrument, or might require C-section at that time. And there are few minutes to decide the decision, to take the decision, and therefore we always keep when the twin is in labor, we always keep the operation theater ready. So that is not possible at home setup. So I'm worried for that thing also. And
okay.
And many times what happens, Monica, when we do the labor in hospital setup, the baby doctor is always accompanied, because many times both the babies might need some assistant and after birth of the baby doctor, or they might need some stay with baby doctor to take care of the babies, which is also not possible at home setup.
I get that. Okay, I understand that, doctor. My point is that what if I deliver at the home, and if some complication arise, I mean, I can come to the hospital. What do you say about that? Because there are chances that maybe the complication doesn't occur, right?
Yes, you are absolutely right, Monica. I respect your point of view also. But there might be some unavoidable circumstances like traffic, shifting to the hospital, unavailability of operation theater in emergency. And as already told you that there are only few minutes to decide the management option. And if you reach late to the hospital due to some reason I mentioned, it will be worrisome. So I think you have to rethink about your option, but I'm not forcing you. I'm giving you all possible option, and so that you can make your decision. We are here to support you, but as with this age and is your first pregnancy, I'm worried for you.
I understand, doctor. So can I have a little time? I think, yeah, I would definitely like them to be in safe hands. So
yes, Monica, you can rethink, and I will provide you some patient information leaflet. Just go through it, that you can make a good decision about it, and I will fix your appointment with my consultant in another 1 week. Is it okay?
Thank you very much, doctor. Thank you.
Thank you, Monica.
Thank you very much, Archana. Who was this doing the station today? Was it Archana? I think this was somebody else doing the station today. A very well done. It was a perfect empathetic tone. What happened to your tone today? What
Ma'am,
was
my
that?
husband improved me that he listened that recording and he was saying, no, you should be empathetic.
Yeah, so all those lines which I've taught you earlier, I'm so happy that you've practiced everything in the same way. It was such a wonderful station. Every line which you spoke was perfect the way I expected you to speak, the way I have taught you. Girls, I've done this station with Archana earlier, and this is what, but she was a listener. But this time she's active, so she had this, the way she has to communicate in the home birth, but the way she has come up with those lines and telling me for everything, the perfect line which she spoke somewhere in between, I respect your point of view. All these lines were beautiful. Such a good flow and such a beautiful continuity in speaking. This just comes with practice. Now, please tell me, can you see the difference between Archana's last performance, her lack of empathy in the tone, her monotonous tone, like a robotic tone I used to say? And can you see today that the way she was talking, the way she entered into the cubicle, hello, Monica, hi, this is Dr. Archana. And it was like I was astonished by her entry into the cubicle. Yeah? So yes, Dr. Bindu, she works very hard. I know her from part 2. She's one student in which I will tell her that these are the 2 guidelines and you have to make notes. She will take her 12 hours that Sidra ma'am has told me that I have to make notes, so I will make notes. And I remember she was not appearing in MRCPI, but she took my MRCPI course just because that she had to take all the topics and revise all the topics from this. So Archana is a very hardworking student. Archana, see, if I compare your basal level, see, again, I would say that she speaks a language in India. The tone and the way she speaks the language, that was very much affecting her English spoken. And I told her many times, this is just because English is not your language. And with your kids, with your family, you speak that, and that gets like imprinted on your spoken in English as well. That's why your last words, they get robotic, and then you put a full stop and you cut down your last words. Now she's just looking at the recordings and she's speaking after the recordings again and again. This demands hard work. For her, her basal level is way too low in terms of only communication with the patient. She's working so hard, and now she's getting much better than even my UK students who don't know what to speak and where to speak. Few of them, I know that they have a command on the language, but they start speaking extra. They start speaking those lines in which the score is not there. So Archana, hats off to your husband. We always
thank you, ma'am, but whole credit goes to you.
Thank you very much, my dear. We always say that behind a successful man there is a woman, huh? So Archana is proving herself other way around. Yeah. So
yes,
I understand he's always with you when it was part 2 as well, and I'm sure you would do great in part 3 as well, my dear. Ups and downs, they do come. I know you've got a very busy hospital and all, but things would be perfectly fine. Don't worry at all. Okay. I'm glad the way you did the station. It is no, without any confusion, 2 by 2 in information gathering, a beautiful flow in the history. It was such a beautiful rapport building in the history. One after the other, the questions were coming. Communication with the patient 2 by 2, applied clinical knowledge 2 by 2, and patient safety 2 by 2 as well. A perfect station, Archana, very good. A passing station, and every station should be passing. I'm glad that you volunteered for Abir and you practiced just in little time. But I'm very happy that the standard has improved a lot. The rapport building and the empathy in the sound has improved a lot, my dear. Very well done. So I've got a long list. Yes, long list are here for the good points, starting with her name and the age, apologizing for the consultant, agenda making, coming to a mutually agreed plan, information gathering regarding the twin pregnancy, the BMI, allergy, family history, surgical, smoking, alcohol, support, about the best part was that she confirmed the chorionicity, and that was very beautiful of the twin pregnancy she had to do. About the examination, it went great. In examination, just one point, rather than respiratory rate, say the breathing rate, okay? So I'm going to examine your blood pressure, the heart rate, the breathing rate, and the temperature. All right? Okay. Now, then the beautiful heart-winning line, so which I always teach students, which Archana spoke, that Monica, I would just like to reassure at the very outset that every woman has a right as to where, when, and how she wants to get delivered, and whatever you're going to choose for yourself, me and my team of doctors are here to support you in your decision. This is the first line you begin with the negotiating station. Thank you very much, Archana. That really made me smile when you spoke this line, because that is one thing which makes a rapport building go perfect. Then it was, I told about my concerns. She asked about the concern behind the home birth. This is the perfect way of doing that. You always ask the concern. You did feel sorry about my friend's experience. That was very good. And you did tell me that everybody's experience is, different. One individual is different from the other. That was good. You appreciated the home birth. That was perfect. And then you came to your concerns. So this is the ideal way of doing in home birth. And I will tell you all that just in a bit with that algorithm. Communication with the patient, perfect. If she wants home birth, please don't tell the hospital birth first. Remember, the rule of the negotiating is that whatever patient wants first, always discuss that first with the patient. History of presenting illness, pregnancy details, exploring the underlying worries, obtaining views and ideas. What does she want? Why does she want? These are important to go with the mental history. Somebody's mic is on mute. Devya. Okay, I've made that mute. Okay. So never say that I want the consultant-led care because it is better or it is safe. Why? Because it is undermining of your colleague. The midwife's undermining, you don't have to do, okay? So you just have to say that we have two concerns for which we want you to be in the hospital. And as Archana said, that what are those concerns? I'll just tell you in the algorithm. Patient safety was 100% done, and involvement of the patient was in the process. If you respect her wish, she will be supported in her decision. That's perfect. Now, please write down any home birth can come in exam. Like one home birth station was, she's a primigravida twin pregnancy, and she's an elderly primigravida. So you've got three concerns. Patients, students, they make a mistake. They just pick up one multiple pregnancy and they just discuss that. Applied clinical knowledge goes wrong. Okay, so you have to pick up all the concerns which are given in the station. Okay. Now, home birth. Home birth, remember, whenever it comes to the station, the first thing is that you should not be biased and insist the patient for the hospital birth. You are no one to take a decision, remember. That's why I always say that you take the information gathering, and the first point you all have to do is that you ask her. That first point before coming to the negotiating is that you say that, Monica, I would like to tell you at the very outset that every woman has a right as to where, when, and how she wants to get delivered. And whatever you're going to decide for yourself, me and my team of doctors are going to support you in your decision. But may I know what are the concerns behind the home birth so that you can address her concerns? First concern was that about the some bad experience of the friend. Second concern was that she wants a familiar environment and the partner to be with. So first concern was dealt with, like Archana said. I would like to rephrase that again. Monica, I would just like to tell you, first I will be apologetic, right? I'm sorry to hear about your friend's experience. I would just like to tell you that every individual has a different pregnancy and a different circumstances. We exactly do not know that what was the actual situation your friend was going through. However, we are going to take care of your condition in pregnancy and during labor as well, and the team of doctors would be there to take care of you. As far as the second concern is required, yes, we would appreciate, and your partner can support you in the hospital birth as well. So we always allow the partners to be with them, right? So these two concerns I will handle in this case. Now, because she wants a home birth, so I will appreciate the home birth. I appreciate that, yes, home birth, it is a very good choice. It's a familiar environment. It's a comfortable environment to take the labor in. Less chances of intervention, away from the buzz of machines. It is a good support available and you feel comfortable. I appreciate the home birth. It is a wonderful choice, Monica. However, I have few concerns regarding your condition can I discuss with you? The concerns I have is that you're into your first pregnancy, your age, and carrying twin babies. At times in the first pregnancy, we do not know because we don't have any example from the previous pregnancy that how the things would go in labor. There can be some untoward reasons for emergency cesarean section, which I'm afraid is not possible at home. I would like to tell you that women in this age group, they can have the risk of prolonged labor. The chances of instrumental birth are also there. If at all this occurs, we require support from the consultant and in an expert hand, the baby should be delivered. Are you with me? The point regarding the carrying multiple babies, remember that this requires an continuous baby heartbeat monitoring, which I'm afraid is not possible at home. During the labor, there are chances that the first baby gets delivered as Lisa is head down, but at times the second baby turns around and there's difficulty or some special maneuvers or the consultant support might be required to deliver the second baby, as we've got less time to deliver the second baby as well. At times, a decision of a second baby cesarean section can also be taken at that time. I would like to emphasize on this point, Monica, that we've got very less time to make a decision because the baby heartbeat starts getting affected. And I'm afraid if we take this decision at home in case of emergency and you're transferred to the hospital at that point in time, we might not get in time and we might have risk to the baby's life, which I'm sure you won't like to have. Even if the baby gets delivered normally, after the birth of the babies, of the twin babies, the womb gets relaxed. We have to give some special medicines for the womb contraction so that the bleeding is controlled. Again, this is not possible at home. All these points have to be considered whenever patients they come to us with their twin pregnancy. Moreover, the baby doctor has to review the babies and accompanies this birth as well. Again, that would not be possible at home. Are you with me? All these points, I would like you to reconsider your decision and think about all these anticipated complications. I'm sure that you would like Lisa and John to be in safe and healthy outcome would be desired by you. Do you have any other concerns? How do you feel about after the discussion? So now when you'll talk to them about each element, students, what mistake they do is that they just pick up twin and they tell the pros and cons and what are the concerns. Age, they forget, primary, they forget. That means that your applied clinical knowledge is failing. In another exam question, she was a primary gravida, she was with fibroids. It was a huge fibroid. So PPH risk and fibroid risk, that was all there. So any concern can be there. And then you have to pick up those concerns one by one and tell about their anticipated complications. Again, you would like to say in the end that whatever you will decide for yourself, we will respect your wish. And we are here to support you in this situation. In the end, even then she has a right to say no or yes, whatever she wants. But if your counseling is good, like I had this case in my exam, and till 7 minutes of time, probably, yes, I remember she was saying that, yes, doctor, please, I'm ready for the hospital birth. So she was happy with that. And I knew at 7 and 8 minutes of my discussion that I've passed the station. So this is how you have to go with the home birth. Home birth can be any station. Always give benefits first so that she stays comfortable. Before that, please show no bias so that she's comfortably talking to you. Now, students, which they make a mistake, they immediately tell that I've gathered here that you want to have a home birth, and they immediately come to this point. But because you have a twin pregnancy, this, jumping from home birth, not giving them line that they have an option, they have a right to choose, not giving the benefit and coming here. Believe me, after 2-3 minutes, she says, no, doctor, I will do whatever I want. So she's not comfortable talking to you, right? So there's a way you have to negotiate so that she simply falls in love with your statements. And she says, okay, whatever doctor is saying is for my good, is for my betterment. Okay. So if you just do it in this manner, your home birth station would be a superb station exam. Archana was a perfect example. If I compare her previous stations with this and the way she has delivered all those lines which I've taught her. They are perfect. Very well done, Archana. Few things which I would like to change is that, Archana, somewhere in between you said, are you listening? So it's a little rude for the patient, my dear. You can say, are you with me? Or you can say, am I clear so far? So do you have any concerns or query? So anything like that, but are you listening to me? It is at times like, I can say to you guys in the session when I feel that you people are silent in the chat box, but avoid saying that to the patient, okay? You can say, are you with me? Or am I clear so far? Okay, Archana, got that? So just one line I had
Yes,
a little,
ma'am.
yeah. So one line you have to avoid. Avoid saying to the patient, are you listening to me? You just have to say, are you with me? So this is fine. This is a sugar-coated sentence, okay? All right.
Okay, ma'am.
A perfect going, my dear. Spot on past station. So after Ramya, you've really made me happy, my dear. Keep going in this manner. So remember, guys, that introduction, agenda, reassure, and force offer support, information gathering. Appreciate her choice first. Tell your concerns regarding the home birth. Respect her wish, and tell her that after 2 weeks she has to come. She's at 31 weeks, right? So after 2 weeks she has to come to you, and then you're going to document whatever she decides now. Okay, so any questions? Thank you very much, Jyoti. Yeah, Harshiba, thank you. Any questions regarding home birth? It is a confirmed station. 1 out of 3-4 days home birth always comes in exam. Yes, are you clear about the home birth, everyone? Are you people in a better position to handle the home birth station now? Thank you very much, Harshiba. Thank you. Any other query regarding the home birth? Clear? Very good. Well done. Okay. So, so we are moving next to the station. Hello, Dalia. How are you doing?
Dr. Sidra?
Yes,
I
Dr.
have one point.
Please, please.
Dr. Sidra, during negotiation, can we talk to the patient that we have other options alongside midwifery unit?
Only if she's adamant for the home birth. Midwifery doesn't take the multiple pregnancy. Okay?
Okay.
Midwifery, they don't take the multiple pregnancy. Generally, it is only given if she's adamant for the home birth. So you, in negotiating a station, what do you do, Dr. Sabia? That's some midway. So a little higher than home and little less than hospital. So you offer them that it's midwifery alongside would be like closer to the consultant bed. However, midwifery, they don't take the multiple pregnancies, but you can offer if she's still at the end adamant that no way at all, doctor, I just want home birth. So then you can give her a midway. So how about having a midway that you are in the midwifery and not in the hospital, so that if at all some communication, some complication occurs, so we are in communication with the midwife and we can arrange accordingly. Okay. So if she's like, right, I was a role player, I was happy with the consultant, so why to give the midwifery, which is not recommended? But yes, if I would have been adamant on home birth, you can give me a 1 step ahead midway. So, okay, if you're convinced that you don't want a hospital, let's decide for a midwifery. Got that?
Okay, because alongside midwifery unit, at least very near to the hospital.
It's better.
Shifting will be very, yes.
At least it's better than the home, but not suitable as hospital. So if she's convinced with the hospital, why to give the option of midwifery? So if she's fixed on home, yes, then you can give 1 step ahead option, that at least, you know, something safer than home. Yeah.
Yes,
okay.
Yes. Okay.
Thank you very much, my dear. Thank you. All right. So station number 5, there is Dalia. Hello, Dalia. No. Nadra. Where's Dalia? Hello, hello. No? Is she in the attendees? She's not here in the attendees even. Okay, no problem. I'll keep 5th station at the end. So send her a message so that she joins. Dua, Nadra, send Dalia a message. So I'll pause the screen. I'll keep her station for the last station. That's okay. Screen is not moving, right? Okay, so let's do Jyoti's station. All right, thank you. So station number 6. So we've got here Jyoti. Hello, Jyoti.
Hi, Dr. Sidra.
How are you doing?
I'm doing great.
Okay, that's
I'm not
perfect.
prepared again.
It's okay. It's okay. I'll be fine. All right. So let's start the 2 minutes time. Let's begin, please.
Next page, please.
Yeah.
Is there a next page? There should be.
Yes, lots of next pages. Start.
What is MSL? Management of second stage of labor, is it?
Meconium stained nitrile.
Okay.
Start, please.
Okay. I'm Jyoti, one of the doctors, one of the candidates for the exam today. I have read the task and I am ready for the discussion.
All right, so these are your 10 patients, please. You have to organize your labor suite. Please tell me that how you're going to manage each patient, what is going to be priority number 1. And this is your time. Please take your 10 minutes. I won't disturb you in between. Go ahead, please.
Okay, so I see that I have a busy labor ward with 10 patients, and I would prioritize it according to the who needs, according to the need, according to their needs, and I would also specify who does what and what needs to be done. So can I know who are the staff with me? I know it was. Can I see the thing again? So I have a ST1, ST2, and a ST3 anesthetic registrar. Am I right?
Yeah, midwife is also there.
And the midwife with me. Okay, can I go back to the page? Can I go to the next page? So I would first go to room 7, and I've seen that she has delivered about 4 hours back, but she had a massive bleeding of 1 liter. I would just make sure that, sorry, I do not need to go there because it's been 4 hours since the delivery, and she has bled 1 liter, so it's good that someone goes and checks whether her vitals are okay, whether she's still bleeding, and what her condition is. So I would send my ST2 to make sure of that. And the midwife there to be keeping a close eye on her. If everything is fine, then the ST2 can go to the next place. And I would like to go to, wait a minute. Okay, so this would be urgent in a sense that I would like to make sure whether everything is fine. Can I see the first page, please? Then I have this 32-weeker twins who is contracting. So I would go there. This also is urgent because they might be needing assistance during delivery. And I will try to find out which baby is first, whether it's cephalic baby first or the breech first. It looks like the cephalic baby is the first twin. So we would need we'll see how much she is dilated in labor, how much progress she is in labor. We might need to give her tocolytics, steroids, and as well as Mag-Sulf if the delivery seems to be imminent. And this is an IV pregnancy as well. So I would need the midwife to coordinate everything. I would also let the neonatologist know that we have an impending twin delivery. I might like to involve the theater team as well as the anesthetist because there is a chance that she might go for cesarean section, or she might need to be having a cesarean section or instrumental delivery for the second twin. I would make sure that she is given steroids and tocolytics as well as antibiotics if the membranes have ruptured, or if she is in established labor. The need for giving her Mag-Sulf would depend on how imminent the delivery is. I would then go room by room, and I would take the ST1 with me. And if I see room 1, this is a trial of, this is a VBAC, and ARM was done at 2 o'clock. A fetal blood sampling was done at 5. Probably there are CTG concerns because of which the FPS was done, and the pH was normal. So she's 6 centimeters now, progressing well. I will have a look at the CTG. And also, sorry, I forgot to say that in the twins room 5, I would involve my consultant as well, so that the consultant is aware there is a twin delivery imminent. And I would also look for a neonatal cot if it's available. And if not available, might need to do a in utero transfer in case she's not in advanced labor. So for room 1, I would wait and watch, might repeat the, if the CTG is fine, I might wait and watch and see if the CTG deteriorates, then I might need to repeat the FPS in half an hour's time. And if the CTG is fine, I would probably wait and watch and look for the progress. The progress looks fine at the moment. So in the next room 2, I would ask the midwife to be keep a close eye on the CTG and inform us of any changes if there is. In room 2, this is a routine admission for cervical circular. So this is a routine case, and I would keep her till I have settled the labor ward to a certain extent, and this is non-urgent and it's totally routine. For room 3, she has delivered and she's awaiting suture. So I will find out when she has delivered, and if everything, if I can find a midwife who can suture her, I will just make sure that I will have to see whether what kind of, if there's any tears. I will assess the perineum to see if there's any tears, or if there is, if she's fine. If it is just episiotomy, and if it is something which midwives can do, I would ask one of the midwives who can suture to do the suturing. Room 4 is a spontaneous labor who's at 3 centimeter, and she is para 2 at 40+6. So I think this is a routine case which the midwives can handle. I will ask the coordinating midwife to send a midwife to her room who can look after do the CTG and see that everything is fine. Room 5 I've already spoken about. Can I go to room 6? So room 6 is a para-naught at 41 weeks, and she is fully dilated at 5 o'clock. So I would want to know what time she was, what's the time past, what is the time now, and how long has she been fully dilated. If she has been fully dilated for 2 hours, then I would ask the midwife, the ST2 can be there, and the midwife can ask her, can be starting to ask the patient to push, provided there are no complications and the CTG is fine. In room 7, my ST1 is already there, and she would have already, ST2 is already there, and she would have already assessed the patient. And if there is any need for me to have a look, I would do that. And if the vitals are not stable, or if she's still bleeding, I would involve the ST3 anesthetist to have a look. I would ensure that she has a group and save, a valid group and save, so that if needed, we can transfuse her. And then I would make sure that she has a good IV access with wide bore cannulas, and the uterus is well contracted, and that there is no ongoing bleeding. Room 8 is an undiagnosed breech. So I would have sent my ST1 here, ST2 here, and she could probably look at doing an incident reporting. I would assess this lady in labor. I will have to counsel her, and I will have to assess her again, because she was in labor 4 centimeter at 6:30. So she would need, okay, so she's an urgent case as well. So we will need to take her to the theater. I will keep the consultant informed, the anesthetic registrar informed, and the theater team informed. Sorry, I think I should have gone to this room before I came, like sequence-wise. So by the time she's getting ready for delivery, I will need to talk to her. So I would talk to her. I'll ask the ST1 to consent her, and I will keep the anesthetist informed, the theater team informed, my consultant informed, and when she's ready, we can do the cesarean section for her. Room 9 is 8 centimeter, and she has been transferred from home for meconium stained LICA. So I will ask the midwife, the coordinator midwife can assign some midwife who can do a assessment of her, and can do a CTG, and I will review the CTG when it is done. She is 41 weeks +2, so she's post-dated. In her case, a little meconium stained LICA is expected. So I would just keep an eye on her, but by the time I would do the cesarean section. Room 10 is a cesarean section done at 1:30 for PET. So I would send my ST2 there to assess and see her that the vitals are good, her urine output is fine, and that her blood pressure is controlled. I might need to send a PET blood again after, maybe by evening, after about few hours, after 4 to 6 hours. And we will also do all the bloods and monitor her urine output, see that she's fluid restricted, and continues with her medication. Yeah, that's all.
Okay, thank you. So the bell rings. What are you going to say?
Oh, thank you very much for your time.
Okay, thank you very much. Thank you. So how was it, Jyoti? How did it go? What was the problem you were facing? It was like 10 stations and not able to read outside the cubicle, right?
Yeah, so I wasn't able to read outside and make a plan, so it was haphazard. I should have gone to the breech. She was in labor 4 centimeter.
Okay.
This
So
was
this is what happened in exam as well. This came on all 4 days of the 2019 exam, and they said that clearly that in one day it was 10 cases, in all other days at least 8 cases were there. And it was very difficult for students to even complete reading. So what do we have to do in that scenario? It's humanly impossible to read all the 10 cases outside and see that what would be the management plan. Even if you make the management plan, of course, you cannot memorize that. As per your priority, you changed that. You said that breath's gonna be your first priority?
No, it would be the second. After what was there on the first page? First was twins. She would be my first priority, and breech would be second. And by the time I would send, while I'm seeing these 2 cases, I would send the ST2 to see room 7 is all right, because she had 4 hours back, and she had only
where is it written that she had 4 hours back?
4 hours after delivery. It is written. She is 4 hours after delivery.
Yes, so she's having massive bleeding.
Later during the cesarean. Oh, not cesarean. It's okay.
No. She's having massive bleeding of 1 liter and 4 hours after delivery. So after 4 hours, she is into PPH.
Okay, I assume that she has, it is 4 hours after delivery, and she bled 1 liter during the delivery. That's what I assumed. So that's why I changed my priority from here to...
No, this is the case of postpartum hemorrhage, which is going to be first. Okay, which is always going to be first. It's a massive bleeding of 1 liter, 4 hours after the delivery.
Yeah, definitely. If she's ongoing bleeding, then definitely.
Yeah. And you yourself would go there, okay?
Yeah.
Now let's do some sort of tips and tricks for the labor ward prioritization. How we are going to.
Actually, I thought that she has delivered 4 hours back.
I get your point. Now.
We bled 1 liter at that time.
Okay, that's fine. Now, please listen to me very carefully. Lend me your ears for the next 10 minutes, because I will tell you that how we have to cope with this station. Number 1, it is impossible. Don't get worried. The 10 stations cannot be read outside. What do you have to do? You go to the outside the cubicle and you see that how many cases are there. You see that what is the task. So the task is what needs to be done, why needs to be done, and who is going to do that. And you see that which people do you have. It's inside the cubicle as well, okay? Now, out of these 10, please don't start reading start reading A. For example, I would say that I'm in exam, okay? Mrs. A, 40+2, trial of SCAR, ARM at 2, feedback, fetal blood sampling done, and I start making its management plan. Okay, I will do this. Then I will read second, and I will make management plan. Okay, I will do this, and this would be sent. Then I will be going to 3, and I will see the management plan. If I'll do like this, at number 5, bell would ring. I would not be able to manage to read all the 10 stations. So what do I have to do for myself to be smart? I would read case 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 quickly, just the details, gestations, and pick up my topmost priority. Remember, it would be any sort of bleeding at all. Either they give PPH or they give some fit eclampsia. Okay? Any one which is the most important, life-threatening out of 10 stations, your only task is in outside the cubicle that you just pick up that one. That's it. That's it. Otherwise, you will miss up even that one which is the most important priority if you start doing management of each case side by side for yourself. Am I clear about the first point? What do you have to do? Out of those 10 cases, just pick up the topmost priority and the bell would ring. This is what you can do maximum. Am I clear about this point? Only one case which is the topmost priority. That's it. If you fail to pick up the topmost priority, you fail your labor ward prioritization, because this is what patient safety is all about. You should pick up that case which is the life-threatening case. Am I clear about step number 1 of labor ward prioritization? That you're going to pick up the life-threatening case? Clear, everyone? Now you enter into the cubicle and you will do the life-threatening case first. That is, you will go directly. Your starting line would be, I'm going to do my labor ward management. Patient safety would be my utmost priority. I will tell the management of the topmost priority life-threatening situation now, and then I will go room-wise and tell the management plan and task assigned to which staff of mine. This would be your opening line of the labor ward prioritization. I repeat that I will do my labor ward management by keeping my patient safety as my utmost priority, doing the management of my top urgent case first, and then I would go room-wise and tell the management of each case along with its priority and dealt with staff of mine. Am I clear? Your topmost starting line of labor ward prioritization? Am I clear? The 2 points I've told you up till now. Number 1, outside the cubicle, just pick up the life-threatening. Number 2, you will speak this line and start with your room number 7. Always remember that the life-threatening, they often keep in the last 3, 4. They don't keep in 1, 2, 3, because students, they don't manage to read it even. So always pick up the life-threatening and manage that completely. Complete PPH algorithm you have to do. Remember that the life-threatening station, the top urgent station, carries maximum marks, so do its complete management. Then don't fumble from one to the other. Like Jyoti was having a little difficulty. Okay, go to 6 or go to 5 or go to 3. No. Then start from number 1. Manage it, assign tasks, then 2, then 3, then 4, then 5, then 6, then 8, then 9, and 10. And this would be a very smooth labor ward prioritization. Always start with the top urgent and then go in sequence. Otherwise, you start jumping from one to other and you feel that you've missed something. So you will start with the top urgent life-threatening case. Then you will proceed room-wise and cover the following aspects in each. Begin with the background information. Tell points in the history you need to know exactly. Maternal assessment if you need to do the vitals, the abdominal examination, speculum, or the vaginal examination. The fetal assessment if you need to do the cardiotocography, the management according to the case. Then you will tell all these 4 points in each. So in this, you will begin with the room 7. So she's delivered, massive bleeding, 1 liter 4 hours after delivery. It's the topmost priority urgent case of postpartum hemorrhage. So call for help, send investigation, stabilize the patient hemodynamically, find the cause of the postpartum hemorrhage, stepwise medical management, you will speak up. And if she doesn't respond, perform the surgical management. Stepwise, you will speak up the entire algorithm. You will take your 2 minutes for your first life-threatening case, whatever it is, remember. Then start from the room 1. So this patient, start from the background. She's at 40+2. She's having a trial scar, rupture of membrane at 200 hours, and she's going for a vaginal birth after cesarean section. The fetal blood sampling shows a pH of 7.29 and she's 6 centimeters at the moment. She needs review to assess the progressing adequately. Now, what am I doing? Because I've not read these cases. Even if you've read the case number 1 outside the cubicle, inside you can't remember. So you speak the background so that this gets fresh in your mind, and then you speak 2 lines for its management. Now you people get that? Even outside the cubicle, guys, if you people have learned these steps, you've done all these cases, when you reach to 10, definitely you'll not be remembering 1. Am I right? So inside the cubicle, you definitely have to see your case number 1. So once you're done with your topmost patient, the urgent patient, then you read the background and then you tell your management whatever is feasible to speak in 2 to 3 lines. Management never goes wrong. The sequence goes wrong. Okay? So you say that you need to review and assess the progress adequately and review the CTG and repeat the fetal blood sampling if any CTG abnormalities are persistent. By room number 2, it's a routine admission for a cervical cerclage, so needs non-urgent review and consent to be signed after fetal viability has been checked and dating of the pregnancy has been rechecked. By room number 3, she's delivered at 39 weeks and awaiting to suture the episiotomy. It's a non-urgent case. Once the labor ward will get stabilized, my midwife will suture. If at all there's any bleeding, I would ask the midwife to inform me prior. Room number 4, she is 40 plus 6 weeks, spontaneous labor. She's 3 centimeters at 550 hours. She needs review later in the morning with other cases have been sorted out that have had the labor been going, and is the progress fine, or is she having a delay in the progress of the labor? By room number 5, there are twin pregnancies at 32 weeks. They're contracting, a cephalic and a breech, and it's a high-risk pregnancy in vitro fertilization. She needs urgent review. After my room number 7, an appropriate assessment, as she might be in a premature labor and she will need steroids for tocolysis. If goes into active labor, magnesium sulphate, and also the neonatologist needs to be collaborated and coordinated with the NICU availability as well. For my room number 6, she's fully at 500 hours, 41 weeks. Why not delivered up till now? It's 830 hours. She needs review, would send my ST2 and check that what are the findings, how is the vaginal examination. After I deal with my postpartum hemorrhage, would ask my ST3. ST2 was the senior most, right? So I will ask my ST2 to give me the findings so that we can inform the patient and discuss accordingly if we require a cesarean section or an instrumental birth. Room number 8. Now here I'm skipping room 7. Why? Because I've done it at the top, right? She's an undiagnosed breech at 39 weeks, spontaneous labor 4 centimeters. I had a smile when you initiated the incident report, Jyoti. This is how discussion rings into your ears, right? So she needs urgent review to discuss the mode of delivery. So recommended spinal epidural if she wants to go into labor. If emergency cesarean section she agrees with, that should be planned for this patient as well. Now, room 9, she requires an urgent review. She's multiparous women in a 4th labor, and she should have delivered by now. She has meconium stained liquor, and she has been transferred from home. So putting her on a continuous CTG, according to the CTG findings and her labor progress, we are going to discuss about the birth plan with her. She requires an assessment of the fetal well-being at the moment, and according to the CTG, further plan would be decided. By room number 10, she needs review after the cesarean section as patient had a severe preeclampsia. This review would involve her pulse, her blood pressure, the amount of the ongoing blood loss, hourly urine output, and the fluid status as well. Blood tests should be repeated. Very good, Jyoti, you mentioned this point, and medications should be reviewed after the delivery. So now I would be completing this. Again, I will go to the chart and would say, so according to the priority, my topmost priority would be my room number 7 as she's in a postpartum hemorrhage. My second priority would be my twins pregnancy in a preterm labor, and then my vaginal birth after cesarean section. So top 3, you can tell in 10 cases it's fine. Others are non-urgent cases. So it's absolutely okay if everything is fine. Yeah, top 3 you can mention. So after top, your second and third can be shifted up and down. But if you are not putting your high-risk patient as number 1, you fail the labor ward prioritization. The idea is that they are looking at you as an ST5 because you have to manage your labor ward yourself. You have to mention that this is the top most life-threatening case, and that should be number 1. 2 and 3 can be up and down because somewhere only a difference of maybe 1 score is in between the priority to them. But your topmost has to be a topmost. Now, again, I would do a quick recap for all of you. Step number 1 in labor ward prioritization. Outside, just quickly read and pick up the most important. That's it. Inside, speak your opening line, which you all have to note down, and start with the topmost management and completely manage that emergency, please. Don't give scanty information. They want you to be patient safe. Consultant might not arrive in time. So you should be able to handle the emergency situation. Then start from room 1, and for each, send your available step, give the 2 lines management of each, and complete your 10 stations. Come back to the prioritization, emphasizing the point with reasoning, and you complete your labor ward prioritization. Am I clear? Any questions regarding the labor ward prioritization, how you're going to do that? You're passing and you're failing. It depends upon your management of top urgent case, remember. So Try to manage it in a manner that you read the 10 stations and just pick up your high risk case. That's it. Manage it completely in 2 minutes and you're almost there on the passing point. After that, you just require to go room wise and give your 2 lines for each case. Am I clear, friends? Am I clear? Any questions regarding the labor ward prioritization, please? In exam,
Yes.
one more point I have to discuss in exam, that a few of my students, they said that, ma'am, in the laboring case, they also said that now I'm giving you CTG and CTG has become abnormal. So for 2 cases, they interrupted as well. If they're doing that, it's okay. So that means that they've been instructed to do that, all right? But generally, other cases would be very less to discuss, like suturing episiotomy, or for that matter, any patient who has been delivered and just need observation, okay? So we can to each room as emergency. Yes, urgent, top urgent, and semi-urgent, okay? Or a routine case or a non-urgent. So top urgent, semi-urgent, and the routine case, you can say, or for the ones like episiotomy, stitch, and not bleeding. Okay, Abir? Yeah? But first priority has to be spoken clearly, Abir, that this is my topmost priority, number 1, where I would go my staff and call for help. Okay? So topmost priority have to be clearly defined to pass the station. All right. Thank you very much. Thank you. Okay. So is Dalia here?
Dr. Sidra?
Yes, my dear. Please.
I have a question.
Sure, please. Sure.
So there was a lady who is fully dilated. Can I see that slide again?
Sure.
So was fully dilated at 5 o'clock. So yeah, this was, I think, room 6.
Yeah.
And she's paranoid. And she's 41 weeks, which is fine. So if she was fully dilated, I've taken the handover at 8:30, isn't it?
Yeah, that's why I said that she should have delivered up till now.
No, because 2 hours will give for descent if she's paranoid and if she has on epidural, and then 1 hour for pushing. So it's not time yet, actually.
At 500 hours, she was fully, and it's 8:30 now. So 3 hours is the maximum for primary gravidas for the Green Top guideline, Jyoti, yeah? So 3.5 hours have passed, right?
Isn't it 4 hours?
No, my dear. The Green Top guideline has changed. It's 3 hours for the nullipara and 2 hours for the multipara. And 4 hours is only for the epidural, that too in the nice intrapartum.
So we need to find out whether she's on epidural. If she's on
exactly.
epidural,
otherwise, even in the epidural has changed, my dear. The Green Top guideline has changed the hours of birth. Have you seen that table, all of you? In part 2 now, even in part 2, we are doing new hours of labor. The Green Top guideline of operative vaginal delivery has changed the hours. They've said that 3 hours for primi and 2 hours for multi, and that's maximum. They've reduced 1 hour from the nice interpartum, please. Now, Green Top guideline has to be followed because it's recent, and of course, the Green Top guideline is always preferred over the nice.
I was not aware of that.
Okay,
but actually, we give 2 hours for descent and then 1 hour for pushing.
Yeah.
So it's not yet reached that point, actually.
Yeah. So if she is at epidural. Otherwise, it's not mentioned in epidural, so you can just speak 1 line. I would like to know if she's at epidural, even if you're following nice. But in GTG, it has been 1 hour has been reduced, my dear.
Okay, I'll have a look there. Sorry.
Okay, right. No, all right, Nadra, I can understand, no problem. So she didn't tell me that she wants an exchange. So either her station will be utilized or we can skip her station. What do you guys think?
Sorry, I have 1 query here in labor ward.
Please.
And in station number 9, again the same confusion. She is at 2 hours. She was 8 centimeters, and she is multi and meconium stain, and the endorsement at 8:30. So this case also considered as an urgent case. Am I correct?
No. Yeah, this is urgent, but because meconium stain liquor is there.
And also so delay 8 centimeter from 2 endorsement 8:30. And she is multi.
Exactly. So that's why malposition, I mentioned in that malposition, malpresentation has to be seen here, that why is such a delay in labor.
And the classification, it considered as urgent, correct?
Yeah, it would be urgent.
Okay, and in case number 10, I can send the anesthetist to take care of this case because she is postpartum only for the concern of the high blood pressure and PET.
No. Anesthesia registrar would accompany you for PPH, please, because this is life-threatening. Here, even midwife can just do the monitoring. Only observations are required, my dear. Why to waste our anesthesia registrar just to do observation? Here, can manage the fluid management and the drugs and all, So we require multiple help in the PPH management. So you go to the room 7 and take your anesthesia registrar with you. Okay? And for here, just send the midwife because only observation has to be done. It's nothing active here, just to maintain the record. That's it. Yeah, Dua?
Okay, Dr. Sadr. And something else, Dr. Sadr. I heard from the other colleagues that for these cases, usually for every case, there will be a big paper outside, maybe with some blood tests, some CTG.
It was only for 2 cases. So it was not given outside, Dua. It was inside. For example, it happened for 2 cases. I'll tell you that, for example, they are here, right? And in Mrs. A, when you come to this, you said that pH is 7.29. And the moment students they spoke, I would like to have a CTG to see that whether the changes are there or now it's fine. So immediately examiner says this is the CTG.
Yeah, correct. Because if a FBS has been done, there would have been CTG concern.
Exactly. So when you say that CTG, I would like to see that after FBS is fine, the pH is fine. So we would like to know the CTG. So immediately, the examiner puts forward CTG. This happened in 3 cases that they gave the findings. For example, in one case, like you're doing the examination, like Jyoti said somewhere in between that I would like to examine what are the findings here. They put forward the examination findings.
Yeah, because she is 8 centimeter at 2 o'clock. She
Exactly.
should have been examined.
So this happened in exam that in 3 cases out of 10, they either, when you ask for like, I would like to do, they put forward a CTG or they put forward the vaginal examination findings and now please tell. So if still she would be 8 centimeter, Jyoti would be asking, and the examiner says she's still 8 centimeter, you would say that I would plan for a cesarean section. Yeah.
Okay.
Yes. This is how it happened, Dua. In 3 cases out of 10, they interrupted and gave some, progress to that station, to that patient.
Even in room 1, we cannot plan a management unless we know the CTG.
Exactly.
Based on CTG.
Yes. So that's why when you, but it was not in all cases because it takes time. In few of the cases, they simply said that it's, we are just going to do that, this. And you went on speaking, but in like 2-3 cases, they interrupted. Okay, this is your CTG. Now what would you do? Okay, this is your examination. Now what would you do? So that was better. That was easy. That made you decide your management plan quickly, right? Okay.
Yes, correct. But outside mainly, it will be only the scenario for every case, one by one.
Outside, it was just like a table like here.
Oh, okay, thank you, Dr.
Inside, for 3 cases, they interrupted out of 10. Yeah.
Thank you.
Thank you, my dear. Thank you. All right. So no problem, Nadra. We'll just see. What do you say that should we skip Dalia's station? Yeah. Or
skip both the station. Skip both the station, Dr. Sidra.
We are not skipping station number 7 at all. Okay. So Dalia, somebody wants to exchange from Dalia? Anybody? Because Dalia didn't tell me about. Don't skip, Harshiba says. Okay, right. Okay, so let's do station number 7 first, and we'll see that what do we have to do for Dalia station. Okay. So station number 7. That's why I always post earlier that please tell me about your commitment so that there's no, I don't want that your station, your paid station goes to somebody else unnecessarily. There should be either an exchange or you should do your station. Okay, right. So I will do any mini minor more for her exchange. Okay. All right. So let's do station number 7 for Dr. Sabiha here. And what do we have? Even I have forgotten myself, Dr. Sabiha. What did I give you? Hold on. Yes. Okay. All right, Dr. Sabiha. So after a long time.
Yes. After a long time of study. No study. After a long time of no study.
Okay. So 2 minutes is starting. And please begin.
Hello, I'm Dr. Sabia, one of the doctor in the antenatal clinic today. May I confirm your name and age, please?
Yes, hi, Doctor. Dr. Mary Phillips. I'm 30 years.
Is it okay if I call you Mary?
That's okay.
Okay, Mary, what I can understand from your antenatal records that this is your second pregnancy, and in your last pregnancy you had a cesarean section because of the bottom. Your baby was bottom first, and now this is your second pregnancy, and you came here to discuss your mode of delivery. Is that right?
Yeah, exactly. I'm here to discuss my plan of birth.
Okay. Sure, Mary. Shortly, I will be discussing you with the mode of delivery, what the options you have, and with all the risk and benefit, and your choice will be respected. Before that, if I ask few questions, is that okay?
Okay.
Okay. Mary, can you tell me, is there any other concern you have
Regarding?
regarding your delivery?
Yeah. I was just thinking that if everything is fine, if you feel that it's safe, I would like to go for a natural birth. Even last time, doctor, I tried for a natural birth, but somehow Lisa was adamant to be a bottom down. I mean, they tried to turn through the tummy as well, but it didn't work. So I had to go for a cesarean section, but I'm always very pro for a normal birth.
Okay, I can understand your concern, Mary. So, Mary, can you tell me about your current pregnancy? How is your pregnancy so far?
Yeah, the pregnancy is going perfect. It's actually I'm just like 30, around 36 weeks now, and up till now no concerns at all. The movements are fine. John is doing great, and I had an ultrasound that said that it's fine as well. All the blood tests they were fine. Initial investigations were fine as well. So far, so good, doctor.
So, do you have any pain in your tummy right now?
No.
And how is the movement of the John?
Perfect. That's perfect.
Okay. Is there any health concern for which you are following your doctor?
No.
Any surgery other than this cesarean section done on your tummy?
No.
Do you know your blood group, Mary?
O positive.
And do you know your height and weight ratio?
That's 22.
And Mary, whom do you live?
With my partner.
Is he supportive?
Yes.
So you have a good support at home.
Yeah, doctor.
Okay. Mary, in the previous few weeks, do you feel down, depressed, and low mood?
No, not at all.
That's good, Mary. And can you tell me, Mary, some personal question? Do you smoke or take alcohol?
Not at all in pregnancy. Nothing like that, doctor.
Okay, that's good, Mary. So, Mary, do you know what are the options available for you? You have any idea?
Yeah. What I know is that it's going to be a normal birth after a cesarean section. And one is like you go for a cesarean section again. This is what I know.
Okay, that's good, Mary. At least you know that. And one more question, Mary. You had an ultrasound about any of the doctor told you about your afterbirth? It was at a normal position.
They didn't tell me anything that it's an abnormal position, so I assume it would be normal.
Okay. So, and what about the growth? Whether any concern they mentioned?
Growth of?
Your John?
My John? Yeah, he's fine, doctor. They didn't tell me anything like that. They said that like it's according to the duration of the pregnancy.
Okay. So, Mary, there are two options. Let's discuss your mode of delivery this time. There are two options for you. One is vaginal birth after cesarean section. We call it VBAC. And the other one is elective repeat cesarean section. Okay. So I want to tell you about both the risk of both, risk and benefit of both. But I want to reassure you that I will give you both the risk and benefit of both the options, and your respect will be respected. Whatever you choose, me and my team will support you in your choice.
Oh, thank you very much, doctor. That's lovely.
Okay, Mary. So let's first I will discuss VBAC after repeats after cesarean section. Okay. So Mary, both options are safe for you, and but only have some risk and benefit with both. So with VBAC, the first thing is that you have to be delivered in a hospital setting. And the benefit of this vaginal birth, as you know, that's it's like I can say 3 out of 4 women, they have a very if they have a straightforward pregnancy like you, they give birth vaginally following after a cesarean section. And the advantage is they have a successful vaginal delivery, and they have a short recovery, and they have a short hospital stay after delivery, and they have less abdominal pain, and in the future they have a straightforward pregnancy and delivery as well.
Okay.
Are you getting me, Mary?
Yeah, I am.
Okay. But there are some of the risk with this vaginal birth, vaginal delivery, Mary, because there is a very small risk, like 1 in 200 of this scar of the previous cesarean sections give way during labor.
Okay.
And for that we have to monitor your progress of labor, and we have to monitor your baby's heart during labor. Am I clear so far, Mary?
I understand that, Dr. K.
And there is also risk of emergency cesarean section also. In any point, if there is fetal hearts, your baby monitoring is concerning, like your John is not getting enough oxygen or is not happy during labor, we have to go ahead for cesarean birth as well.
Okay.
And there is, like all vaginal delivery, there is a very small chance of the John getting less oxygen during the delivery process. Am I clear so far, Mary?
Yes, Doctor, you're clear. So, do you think that I should go with a cesarean section now? I'm a little scared of the vaginal delivery.
Mary, actually, let me discuss about the cesarean section, risk and benefit of all. Then you will be given patient information leaflet. You have to study. You don't need to decide right now. You study and then think about that. After that, you choose whatever you decide. So let me give you some points about the repeat cesarean section. Yes, this is the advantage of repeat cesarean section is that there is no risk of a scar giving away during labor.
Okay.
And for the baby, also there is no risk of like lacking of oxygen during delivery process. But during with the cesarean section, there is a very small risk of your baby having breathing problem. If it is done before time, or even if it is done at 39 weeks, then there is a very small chance. For that, the pediatrician, they are the one they will need to take care of the baby, and it might need some observation. Am I clear so far, Mary?
Yeah, I get that.
But Mary, there are some disadvantages for the cesarean section. As this is a surgery, you have to be in the hospital. Your recovery will be little delayed. You have to stay more in the hospitals, and you will be on medications for your pain relief, because you have to scar on your tummy and on your womb as well, and there is a risk of heavy bleeding, and might need blood transfusion as well, and there is a risk of clot in your leg and lungs also. Am I clear so far, Mary?
Yeah, I get that, Doctor. Right. So, what do you think is otherwise fine for me? I mean, if you would have been at my place, what would I have chosen for your baby?
Actually, Mary, the choice will be yours. Both options are safe for you. So just take your time read all these information leaflets, and then decides for you.
Okay, just
Discuss
wanted
with
to,
your partner.
I will do that. Just wanted to know that what if I don't go into labor? I mean, you said that it's gonna be like a normal birth. So what if I don't go into labor? What would happen then?
If you don't go into your labor, like you pass your due dates, then in that situation, it's better to go for cesarean section for you.
Oh, okay. So there's no point that you can kick off the labor.
There is a risk if you start your labor, if you induce, like you decide to even go for vaginal birth after cesarean section, and you want to go for induction of labor, then yes, you can go ahead for that induction of labor, but there is a slightly more risk of your scar giving way during labor in case if you induce your labor with the help of some medication.
I get that. Okay. So just give me a little time. I'll just get back to you with my decision. I think I'll go for a normal birth so far.
Sure, I'm giving you some information leaflet, just like vaginal birth after cesarean section and induction of labor and the risk and benefit. Just read that and discuss your partner, and I'm giving you appointment with my consultant. And whatever you choose, we will hear. Me and my team will respect your wishes and will support you in all your whatever you choose for you.
That's perfect. Thank you very much, doctor. Thank you.
Thank you, Mary, for your time.
Thank you very much, Dr.
And thank you, Dr. Sidra, for your time tolerating me.
How was it today? Yeah, how was it today?
Actually, Dr. Sidra, I frankly speaking, I told you already, for maybe a month, I'm not, I'm not doing anything.
I think I should talk to your son that he should start taking your classes because he's here. So I'm sure.
No, my son already told me, Mama, now everything is finished. Now you start your study now.
Now, and I'm sure when he'll talk to you, definitely your language would also improve. I'm 100% sure. So I'll ask him to give you tough time now. To become a very bad role player and start communicating with you like an examination. So at least we can take benefit from online classes. Yeah.
Sure,
so I'm going to call him and guide him that how he has to make you prepare instead of having movie times. Yeah.
Yeah. Inshallah.
Okay. All right. So very good, Dr. Sabia. As compared to the previous stations, it was a good station. Few points I did have noted, but today I could sense a little confidence in your sound. You were not shaky today. I mean, you were talking like the way one should talk. You were not very nervous. Specifically, speed in the information gathering was good, Dr. Sabia, today. So it was not slow as compared to the older, stations, which I used to feel that you were slow. So things are definitely improving. It was much better than your previous SPT. So that's a good thing. At least that is reassuring for me. So when you entered into the cubicle, your introduction was fine. When you entered into the cubicle, I was like, yes, doctor, I'm Mary Phillips. I'm 30 years. When I'm having a little smile, why are you very serious? You said that, okay, so it's okay, I call you Mary. So if I am a little cheerful, I mean, when I'm a little cheerful, I said, you could have said, okay, thank you.
Dr. Sidra?
Yeah.
Didn't you get that I'm not in a mood of doing anything today?
So please listen to the recording. Listen to my tone and listen to your tone.
I will listen.
I was like so cheerful with you as a patient. It seemed that I am a doctor and I'm trying to make a repo building and you are trying to be very serious. And so it's okay. It's okay. So don't like this, okay? Give a little smile. I mean, give a little cheer to her as well because she's very happy to meet you. So you can be like, yes, okay. So it's okay. I call you Mary. So it's like, it's okay, I call you Mary. So, I was like, I mean, why the doctor is so serious? Yeah.
You are a magic, actually. You are a magic. You are a magician, actually.
No. Please don't do that. I've noticed every line, the way you were speaking. See, I want a perfect tone in response like the patient is. If
I know you laugh at one point. I want to know why you laugh at that point.
At your jaw is moving. So I wanted to correct you at that point. No, it's nothing like your John and your Lisa. You say that how is the John's movement? How is John moving? Okay. So I'm talking about your John growth. So that was something we need to improve. Okay, I'll come to that point. All right. So let's begin introduction. Introduction was fine. A little cheerful voice. If patient is cheerful. If patient is serious, just match the tone with the patient. Agenda was okay. Your agenda was that you're here. Instead of mode of delivery, Dr. Sabia, better is plan of birth. You're here to discuss about your plan of birth. Okay?
Okay.
This is a better way. Mode of delivery is like what we discussed with ourselves, like in the colleagues. You say the plan of birth. Now, information gathering started with a concern. So concern can be after information gathering, before the management plan, right?
Okay.
First take the information gathering, then come to the concern. So information gathering was fine. You did ask a good information gathering today. How had the pregnancy been so far? The movements, medical history, surgical history, blood group, the BMI, the partner support, and smoking and alcohol. You said that I appreciate. And I said everything is going very fine up till now. So you can say happy to hear about that. So anything like that in a gesture, gestures were missing. Go to the recording. I was so happy to tell you that everything, all the investigations were fine. And you said, okay, any other medical history you would like to tell? So you were a very serious doctor as compared to the patient who was very happy to see you. So a little gesture in response, happy to hear about that. Okay, anything like that which shows that yes, rapport building is going good. So patient was trying to make very good rapport so that doctor doesn't get confused today, but doctor was trying 100% to make patient serious. So make a good rapport the way according to the patient is trying to talk to you. All right.
Okay.
So then ultrasound, you came about that this was asked. You asked about that. I told you that it was all normal.
I have one question, Dr. Sidra. I'm sorry, I'm interrupting you.
Yeah.
This patient, it's written already in the scenario that everything is fine. There is no other, and the pregnancy is well. And the patient is also say everything is fine. So I was little one point confused whether I need to ask the growth and the like localization of the placenta or anything.
Yeah.
Or it's I will get it. Everything is fine.
No, this would have been in the HOPI. You asked later. This would have been in HOPI, and I'll tell you what 3 points had to be in HOPI which you didn't mention. Okay? I will tell you that what 3 points I've noted down which had to be there. So then you told about the advantages of the VPAC, the disadvantages, that was good. You told about the emergency cesarean section chances, that was fine. Elective repeat cesarean section advantages, disadvantages, and the best thing was that in the end you said that me and my team of doctors are going to respect you, whatever you're going to decide for yourself. So take your time, decide accordingly and all. Okay. Now, in the beginning, I've written on the points to improve that a little smile in entry provided the patient is a cheerful patient. Then plan of birth instead of mode of delivery. Now, in HOPI, 3 things were missing. 2 things you mentioned in the end after completing your information gathering template. And 1 thing which I wanted you to speak very clearly in the HOPI. In a previous cesarean section, remember, you took the history in HOPI about the current pregnancy. Did you take the history of the previous pregnancy?
Yes.
If you never ask a history about the previous pregnancy, you fail your patient safety because you cannot determine the eligibility criteria for a VBAC. So after asking the current pregnancy, I would say, may I ask a few questions regarding the previous pregnancy? So how was your cesarean section? Did anybody talk to you about where the cut was given? Did any detail in your discharge notes were mentioned about the future plan of birth? I would like to review the discharge notes if you could bring next time. Yeah? How was your recovery after the cesarean section? These 3 points I would definitely say to tell to examiner that I'm excluding any chance of any upper segment cesarean section. Clear?
Yes, clear. It was in my mind. It was in my mind, but the patient was so happy that I thought there will not be any problem.
So all blames to the patient, yeah? All blames to the patient. All right. So remember, the current pregnancy has to be taken and older cesarean section history is mandatory because I was saying again and again, is it safe for me? So you have to determine it's safe for me, right? Yeah?
Yeah. Yes,
okay.
Yes.
Then I would like to ask here, so in this current pregnancy, was ultrasound performed and did anybody talk to you about the afterbirth location? And I would like to know about your recent scan. How had the John been growing? And did anybody talk to you about weight according to the pregnancy? That's it. So I'm excluding any sort of heavy weight for VBAC. I'm excluding any sort of IUGR for VBAC. I'm excluding any sort of placenta previa, all these things. I would do an HOPI. These 3 questions are not only your information gathering, they're also your patient safety. Okay, so this was missing in the information gathering. For that, I've given you 1.5 in information gathering, not borderline, not passing, somewhere in between borderline and passing. Then I've written that that instead of short recovery, like you gave in the advantages of VBAC, you have to say that the recovery would be quick. So it's a quick recovery and a shorter stay, my dear, not a short recovery. Okay, just rephrase that, my dear. We have to say it would be a quick recovery and a shorter stay in the hospital as compared to the cesarean section. So short recovery, it's not there. We have to rephrase together. We would say quick recovery and shorter stay in the hospital. Okay, so quick.
Okay.
And
quick recovery.
Yeah. Then one more thing. When I asked you the question regarding the induction of labor, their applied clinical knowledge went wrong. You said, if you don't go into labor, then we would plan cesarean section. It's not like that. Again, we've got 3 options. Okay. And I will tell you that how we have to say that. All right. Okay. So in terms of the communication with the patient and the relatives, yes, a little more be according to match the tone to the patient's tone. Otherwise, today it was much better. You were not scared today. Generally, when you talk to me, other than the station, you're very confident. Generally, when you talk in the station, I feel a little nervousness. Today, Dr. Sabia, nervousness was not there. So I was happy about, like, you were like, yes, I have to speak like the way I do that with colleagues. Okay, so that was very good. Yeah. So information gathering, just 3 points, which I've told you. Communication with the patient, I'm passing you today, 2 by 2. Applied clinical knowledge, I'm giving you 1.5 just for 2 reasons. I'll tell you. Patient safety, again, 1.5, and information gathering, 1.5 as well. Coming to the patient safety, confirms no contraindication to VBAC. That was not done. You know, if you don't confirm any contraindication to VBAC, your patient safety is not passing. Pros and cons was fine. You were good in that, and you were very good in negotiating. Like, I didn't have any problem in, like, you undermining my thoughts or something. In applied clinical knowledge, I will ensure that previous cesarean section, no contraindication is there. I will, after information gathering, ask her, so may I know that do you have any concern or wish for your plan of birth? So Dr. Sabia, instead of starting my information gathering with the concern, because I cannot settle that concern right at that point. So I will take the information gathering. After information gathering, when I'll come to the discussion of the plan of management, here I'm going to discuss with her that what is her concern first, so that if she asks for ERCS, Dr. Sabia, I will discuss pros and cons of ERCS first. If she wants VBAC, I will discuss plans of VBAC first. Got my point? Why do we ask concern here? So that we can discuss what she wants. Again, I would tell her that it's going to be her wish, where, how, and when she wants to get delivered. So for VBAC, I will say that yes, there are certain advantages, that the surgery is avoided. It's a less hospital stay, a quick recovery. Chances of future normal births are there, and less tummy pain after the birth as well in terms of quick recovery. However, there's some risks to the mother and the baby. Here, I have to tell you one point, Dr. Sabia, remember for life, all of you, please, it doesn't go for Dr. Sabia because in flow, you people do that. Now, once she, unfortunately, poor patient has told John, so John's growth, John's movement, John's simply the ultrasound of the everything, you can mention for the positive things. Yes, taking name once is fine. I would repeat, taking name once or twice is fine. But saying that John will have less oxygen, brain can be damaged, this has to be avoided. She has told you the name, but don't associate complications with that name, please. Am I clear? This is a very tiny point, but this straightly goes to the heart of the mother. Don't associate name with complications. This is not only here. This is in maternal medicine as well. Do you people remember when I had to tell you that in any sort of diabetes, a patient has a maternal complications and a fetal complications? You always say that women with this condition can have this, rather than you can have this. Do you people remember my statement?
Yeah, we remember.
In the baby, you have to say babies with the women in this condition can have this. rather than saying John can have this. So
Okay.
at one point, I have highlighted it clearly when you said that John can have less oxygen. This is very, very heart touching and a sensitive point for the mother. What you have to say is that generally in the vaginal birth after cesarean section, there's a chance of an emergency cesarean section. At times in labor, scar can open up and get ruptured. There's a risk of blood transfusion and infection, and women can have delivered the baby, and there can be brain damage to the babies as well. So here, I'm not going to associate with her baby's name. Am I clear, everyone, please? This is a very tiny point, but a very important point for a layman assessment. Layman is exactly assessing at this point that how do you communicate? How do you take care of patients, communication, and rapport building? Everybody is silent in the chat box. Did you people understand that? Because in flow, it happens that you would say that Sidra has taught us that once name has been told, you have to take the name on everything, not for the complications, please. Not for the complications. Okay, this gives a very negative impact on mother. It's sensitive. Mother is sensitive about that. She can get angry on that. Now, for elective repeat cesarean section, the benefit is that there's no risk for the scar rupture, avoiding the risks of the labor, no risk for the brain damage, the stillbirth of the baby, and the benefit is that we can plan the date of the delivery. However, some complications to the mothers can happen, like that of complications of the damage of the surrounding structures, clot formation in the legs and the lungs. It takes a longer time to recover. There can be increased hospital stay. And for future, the chances of low-lying afterbirth or the afterbirth after every cesarean section has a risk to invade into the scar. This risk is increased after every cesarean section. For the baby, there can be a risk that the baby has a breathing difficulty after birth from the cesarean section. Am I clear so far? Now, Mary, if you don't go into labor, we have got three options again. If you reach your due date, still we can see that how is the baby moving, how is the fluid around the baby, and we can take the pregnancy till 42 weeks by simple sweeping the membranes, that we might do some watchful waiting with the CTG monitoring, that is a continuous baby heartbeat we are going to do with the intervals, and to see the fluid around the baby. We can wait for another 2 weeks provided the movements are fine, provided the fluid around the baby is fine and the heartbeat monitoring of the baby is satisfactory as well. If we have any concerns, we have an option of giving an artificial pains. However, I would like to tell you that artificial pains in women with previous cesarean section is risky as compared to normal women who have normal vaginal births earlier. There can be increased risk of scar rupture. Therefore, we try to give the artificial pains either with the tube inflating, or we give it half the dose of the tablets to kickstart the labor as compared to other women. However, this would be decided at that point, looking at the state of the neck of the womb, how far it is softened and how far it is dilated. If your state of the womb allows, we would discuss with you the artificial pains. However, if it is tightly closed, it's not softened, we might take the decision of direct cesarean section at that point in time to avoid the risk of the scar giving its way or failing of the artificial pains. Am I clear so far? So Dr. Sabia, we have to justify that induction of labor in a good bishop. We do simple dilatation with Foley's and it can be done, or simple half the dose of the prostaglandins can also be given, provided bishop is satisfactory. If bishop is not satisfactory, you don't take the risk, you go with elective cesarean section. So 3 options are there rather than telling only one option. Am I clear, everyone? Did you understand that this is her question in exam? She says that what if I don't go into labor? So you've got 3 options. Clear, everyone? Yeah? So mechanical is preferred as per the NICE guideline. Okay? Yeah? Very good. Well done. So For the outline, introduction, agenda, reassure and offer support, information gathering, appreciate her choice first. She wants VBAC, discuss that, and tell the concerns about the VBAC and ERCS. Remember, there's one question which these patients, they ask as well. And that question is that, what if I want a VBAC and that too at home? So again, you should be ready with some lines. Dr. Sabia, what are you going to say? If it's going to be, if I say that, doctor, I want a normal delivery. So what if I plan a home birth?
Right. I can understand your concern.
Very
and
good.
your choice will be respected.
Very
your choice
good.
will be respected, but I am afraid because you have a previous scar, and as I told you,
No,
if you go
I'll
for-
here stop you. Hold on. Starting is very good. You have to say, I respect your concern and your choice would be respected. However, I have few concerns regarding this condition. Can I discuss with you? Okay. So please say that now. I have few concerns. Just always remember, you have to cram up this line so that there's no confusion in exam. Now say that again. Okay, start from the beginning. Yeah. Doctor, I want, can I have this at home, the normal birth at home?
Mary, I respect your wishes, and we will support you with your choice, but I'm afraid I have some concern regarding you, as you have
regarding your condition, not
your
you.
condition. Regarding your condition, as you have previous cesarean section, and this is going to be vaginal birth after repeat cesarean section, and as there is a small risk of scar rupture during labor. So you need monitoring, which I'm afraid it's not available at home.
Very good. Well done. And you need the support from the, there can be any, at any point in time, we might require to take a decision for the cesarean section in emergency.
Cesarean section.
So we need to consider that as well. I hope you understand. Okay?
Yeah, I hope.
Okay, very good. Well done. This is one question a patient also puts in the end. Okay? Very well done. Okay, thank you very much, Dr. Sabia. It was a wonderful station as compared to the previous one. If you can improve without studying, I'm sure you will improve a lot with studying.
Yeah, okay? Inshallah, Dr. Sabia. Inshallah, we will do, inshallah.
That's like my Dr. Sabia. Well done. Okay. So, station number 5, guys.
Sorry, one question again.
Sure,
Dua, if the same patient came with previous to CS and she requesting VBAC, what will be the applied clinical knowledge for this case?
Okay. It would be same. It would be same. Previous to cesarean sections, it is said that the chances of scar rupture are more, but you will discuss the same points of VBAC and ERCS, but telling her that evidence suggests that it should be a cesarean section because the risk after 2 scars giving in labor, scar giving its way and opening up is way too higher as compared to a single scar. However, again, your choice would be respected. So your emphasis would be more, you have to discuss pros and cons of each. It is her choice. However, your emphasis would be more on the evidence that for previous to, it is suggested that you go with the cesarean section direct, elective repeat cesarean section. Okay.
Okay, because what I got some confusion in this guideline for VBAC, they said for previous to cesarean section, she can go for VBAC, very little higher risk of increase the incidence of scar rupture.
Yes.
So
now after previous to, they say it's an absolute indication. The guideline says it's an absolute indication for cesarean section. Till +2, they say it is not suggested. However, it happens many times that previous to comes into like 7-8 centimeter and we are having palpitation, what would happen, but she delivers. Yes. So previous to can get delivered, but again, you will tell the pros and cons, more emphasis on the rupture point.
That's it.
Okay. Otherwise the pattern will be the same.
Okay, thank you, Dr. Saxon.
Thank you, sweetheart. Thank you. All right, so Dalia is not here. I've just seen the WhatsApp. She is committed in some emergency. So guys, Abir was really committed. She was occupied, not well for the last 1.5 weeks, but I'm really glad that she just messaged me on private that she is ready to do the station because her own station was done with Archana, but hats off to her. I really like her attitude. She's very positive towards life. And believe me, very less students are so positive as I found Abir always. Abir, can we just listen to your voice? Hello.
Assalamu alaikum. Thank you, Dr. Sadra.
Walaikum
Thank you.
assalam, my
You are
dear.
very supportive to me in the
I'm
situation.
really grateful to listen to your voice. I wish you all the health in the entire world, sweetheart, that you get better soon and we enjoy the same pattern of life, inshallah soon. Okay.
Thank you very much.
So you are a strong girl and you have fought a lot, and I'm sure everything will be fine. You will be very well soon. And I'm listening to your voice. That's a big thing that you just messaged me in private that you're ready to do that. I requested Archana. She did your station, but just in this way that you're volunteering, that shows you will definitely make this exam. I'm all available for all the support, Abir, and it's my responsibility to take you through. So don't get scared anytime to just discuss any point with me, okay? And we definitely make it, my dear. So take care of your health and everything would be fine. The most important thing in life is the not studies, of course. It's health. If health is there, everything comes sidewise, okay? So everything would be fine. And you've got lots of blessings with you, okay? All right. Okay, so let's begin with the station number 5, friends. It's the last station of the day. Today, 2 very good performances, one by Archana, one by Ramya, and third good performance by Dr. Sabia as well. So we are going to improve together. This is going to be 2 minutes time. Yes, go ahead.
Okay, next slide. Okay, doctor. Shall I start?
Yeah, we've got 10 more seconds.
Okay.
Okay, let's start. Wait.
Hello, I'm Dr. Abir. I'm one of the candidates of the exam, and I'm ready for discussion.
Okay, so Abir, we've got a patient who has just collapsed. So can you tell me what is going to be your initial management for this patient?
First of thing, I want to manage my patient. I want to ensure she is in a good and safe environment. I want to check if she's respond to stimulus or no by tapping on the shoulder. Hello, are you okay? Are you okay or no? If she's responds, okay, I will keep her on recovery position and check the vital sign, observe her by new chart. If she's not respond, I want to call for help. All the team, consultant, obstetrician, consultant anesthetist, hematologist. I want to start by check the airway. There is any obstruction in the airway. A careful look and feel and listen. There's any, can I check her breathing, if she's breathe well or no, check circulation. If she's not a breathe, I will start by my CPR.
Okay. All right. So what can be the causes of maternal collapse?
Yes. It is first of thing is thrombosis, thromboembolism, toxicity either to the local anesthetist, certain drugs, magnesium sulphate, cardiac tamponade, tension pneumothorax, hypoxia, hypovolemia, hypo, kalemia, hyperthermia, eclampsia, an internal hemorrhage, intracranial hemorrhage, and also inside the labor ward, the uterine inversion also can cause maternal collapse.
Okay. So what is the further management of this patient according to different causes?
For this patient, I want to keep her in a certain position to be tilted about 30 degrees. Start by CPR. If she's not respond, I will do the postpartum C-section. It should be done in the minute number 5. It should be done in the minute number 5. I want the physician to be in the to be with us in the site of the operation to care of the baby. My CPR is 30 compression, 2 ventilation until the defibrillation machine come. When the defibrillation machine come, I want to check my patient if it is shockable or non-shockable. If it is non-shockable, I will continue for my CPR. If it is shockable, I will, the machine already, it will be act automatically, so I will put the adhesive paddles and start to give shock. Before give shock to the patient, I will remove all the I will remove the tilt from the patient, keep her in supine position. I remove the CTG if I put anything for monitoring of the baby. I will inform my colleague around me. I will give shock to the patient. Then after give the shock, which is either biphasic or monophasic, I will continue for my CPR until the intubation decided or not. If I keep my patient on intubator, I will keep her on 100 compression, but it should be desynchronized with the it should be desynchronized to be not at the same time within the compression should be not at the same time within the ventilation. For this time, I should see what are the cause and treat it. If it is for toxicity, I consider give the patient adrenaline or another drug such as amiodarone or else.
Okay.
Okay.
So what do you understand by perimortem cesarean section, and when do you require that? How do you perform that?
Okay, perimortem cesarean section. It is a C-section done after patient be pregnant of 20 weeks, because after 20 weeks there is an aportocaval compression by the uterus. So I will do it if the patient not respond to the CPR after 4 minutes. At the minute number 5, I should do my C-section. It is a crash C-section by just I need a scalpel because already there is a very low or negligible venous return. The type of the incision, whatever the operator be trained on, it is not a matter if it is longitudinal or straight or transverse. If the operator it is well trained for each incision, he can or she can go with it. I do it because okay.
Okay.
Pediatrician should be with us if the gestational age is more than 22 weeks for sustain the baby.
All right. So you do at the same place, or you just change the perimortem cesarean section, you shift to the operation theater?
If the patient is alive and respond, I will shift the patient to the theater. I complete the cesarean section by ordinary way and keep the patient in under observation in critical care unit.
Okay. Right. Anything you would like to add in any of the questions? We have got few seconds.
I don't know. I don't know. I think in the question number 1, what's your initial management? I think I should use SPAR.
You should use what?
SPAR tool.
Sorry, again, you should use what?
SPAR tool.
A SPAR tool. Okay, okay. Yeah, you can listen to a little background, and you can start. Very good, Abir. A wonderfully done station, a very good composed knowledge regarding the station as well. So this is the type of a station I can understand, which is a small structured discussion. You can end early as well. Very well done. So initial management is that you're going to start with your ABCD approach. That is, airway, breathing, and circulation has to be done. If the spinal board is available, left lateral tilt from head to toe 15 to 30 degree. If not, above 20 weeks of gestation is going to be a left lateral manual displacement of the uterus. It would be done. Intubation would be considered in unconscious women with a cuffed endotracheal tube and supplemented by high flow oxygen. Bag and the mask ventilation is inserted in some supraglottic airway. You clear the airway. If still no breathing, immediate chest compressions are started and 2 wide bore cannulae, minimum of 16 gauge, inserted as soon as possible. If no peripheral access, we will go for the central venous or interosseous access of the venous cut down. Now, aggressive approach to the volume replacement would be there, and caution would be taken if the patient has preeclampsia or eclampsia. An abdominal ultrasound to rule out concealed hemorrhage in emergency, and defibrillation energy levels would be same as in the non-pregnant women. All the algorithm of the drugs and the resuscitation protocol would be followed, and we will consider the reversible causes of maternal cardiopulmonary arrest. So ensure a safe environment. Check, stimulate, and assess response. If not, shout for help. Open the airway, check for obstruction, check for the chest movements for assessing of breathing. If no breathing, stop CPR. If no breathing after starting CPR, it would be 30 chest compressions at the rate of 100 per minute and 2 ventilations. Now, once the defibrillator arrives, attaching the defibrillator, we are going to assess the rhythm, if it's ventricular fibrillation or pulseless ventricular tachycardia. 1 shock of 200 joules biphasic or 360 joules monophasic would be given. And if it's a known defib rhythm, that is asystole or pulseless electrical activity, it would be resuming the CPR 30:2 ratio, 30 compressions with 2 ventilations. Continuing with the CPR, high flow excision, and the IV access intubation, correcting the reversible causes and giving adrenaline every 3 to 5 minutes. That's important. And consider amiodarone, atropine, and magnesium as well. This was the initial management all algorithm. Now the causes 4H and 4T: hypovolemia, hypoxia, hypo or hyperkalemia, hyponatremia, hypothermia, thromboembolism, toxicity, tension pneumothorax, and tempora. Eclampsia and preeclampsia can also be the cause. Now, in ongoing management, informing the senior staff and see what is the cause. If it's an APH, prompt delivery of the fetus and placenta, cesarean section in massive placental abruption, IV tranexamic acid reduces mortality due to PPH as well. And if it's an pulmonary embolism, we are going to go with the thromboprophylaxis. And if it's an amniotic fluid embolism, supportive management would be done. If it's a coagulopathy, early aggressive treatment, fresh frozen plasma would be given. Recombinant factor 7 would be only if coagulopathy is not corrected by the massive blood component. Septic shock management according to sepsis 6 bundle. Cardiac cases would be with the help of expert cardiology team. If it's magnesium toxicity, slow IV injection of 10 ml, 10% calcium gluconate would be given. If it's a lipid rescue is required for local anesthetic toxicity, it would be given. Eclampsia management would be according to the magnesium sulphate, the guidelines. Anaphylaxis would be again starting from the airway, breathing, circulation, and giving adrenaline according to the treatment dose for the anaphylaxis. Now would be the outcome. Fetal-maternal outcome depends on the cause of the collapse, the gestational age, and the emergency care provided. The neonatal team, as you correctly said, Abir, would be called over 22 weeks of gestation. Incident reporting, don't forget, please. It's a patient safety, maternal collapse, and death of the patient has to be an incident report and reported to the MedBrace UK. And multidisciplinary training for support and maternal collapse management to all maternity staff has to be done. Abir was very clear about the perimortem cesarean section, friends, that if no response correctly after the cardiopulmonary resuscitation, within 4 minutes of maternal collapse over 20 weeks, it has to be undertaken immediately in the same setting. So incision with the most rapid access has to be given, either midline vertical or suprapubic transverse incision with a scalpel and umbilical cord clamps, that's it. So this is how this station of structured discussion went in exam. Very well done, a very good station attempt, Abir, despite being busy and committed and occupied, my dear. Wonderfully done station. This was an easy station as compared to the stations which were coming in the labor earlier. And this structured discussion, I think it was typically taken from the algorithms and the tables in exam. Any questions regarding the structured discussion? Yes, my dear.
Dr. Sidra, we cannot include the uterine inversion within the maternal collapse?
That would be after delivery, right? She's actually in pregnancy right now. Yeah. Oh. So you would say that it can be, because now she's at in pregnancy coming to the collapse, like antenatal collapse it is, right? Mm. Yeah. So that's why I skipped that option. Otherwise, you can put in the option, that's okay. But if it's after delivery, a collapse occurs, yes, inversion can cause this vasovagal syncope.
Thank you.
Okay. All right. Thank you very much. Thank you, my dear, for a wonderful attempt. I'm really grateful, Abir, and I'm lots of prayers for you. Okay, so we are going to do postpartum next time. Introduction, agenda, history would be same. Always ask about how are you feeling after delivery. Always ask about the pain or discomfort she's having. How is the bleeding? Are you generally well? Any fever or cough? If the patient has some complaints, settle the complaints, example, painkillers, anti-sickness medicines, oxygen mask and all. Okay, so this is going to be your agenda. If she's having some pain, please settle that complaint. Always start with if she's happy or if there's no complication. Congratulations on arrival of your baby, and then start asking questions. In complaints, you have to ask about any problem with the breast, waterworks, bowel movements, pain or swelling in the legs, and is the baby latching well? In obstetric history, tell me about your previous pregnancy, mode of delivery recovery, about the gynae history, smear, specifically in the high-risk patients, the medical history, family, surgical, drug, personal, social, mental in the same way. If it's a postpartum complication like that of an embolism, you will miss that, okay? If it's a postpartum embolism, of course, you won't ask about the BMI, smoke, and alcohol. Remember that, please. Now you're going to examine her. In this, I would add on examination. Along with that, vitals would be taken, abdominal, chest, breast, and leg examination in the postpartum patient I always add, okay? Generally, what we do in the modules is that vitals, abdominal, and vaginal examination we do, but here we're going to add the chest, breast, and legs as well. Management would be according to the case. MDT if required, like pulmonary embolism or the perineal tear. Discuss the breastfeeding and contraception always because it's a postpartum module. And for the next pregnancy, for early booking. So if any concerns are left, you address that. You complete your discharge plan for the postpartum period or ask her for the follow-up if it's a morbidity which requires another checkup. Am I clear? Yeah? Any questions, my dear? So we are doing after 2 weeks the postpartum. It's going to be on Friday. Yeah?
Yes, inshallah.
Okay, so let me see the date. It's going to be 19 and 26. Would that be 25th? Am I right?
Yes, it will be 25.
Okay, so it's going to be 25th of September. All right, let me write down. Okay, 25th of September, we will have the postpartum module and the topics I'll just be posting in a while. All right? Okay. Any questions, please? Thank you, Divya. Thank you, Bindu. Thank you, Archana. You must be tired, all of you. Thank you very much for a wonderful discussion. And I want to see a little improvement next time. Everybody should be well prepared. Today, 2 or 3 stations were exceptionally good, but I would just want that those 7 stations in the next session, they go exceptional, all of them.
Thank you, Dr.
Thank you
Sidra.
very much.
Thank you very much.
Thank you, Dr. Sabiha. Thank you, Abir.
Thank you very
all
much.
of you. Take very good care of yourself. Have a good dinner. Take rest. Tomorrow, just revise all these topics from the recording and complete your templates. Take 2 days to complete the template so labor is done, and then you move to the postpartum. Okay, thank you very much, Nadra. Thank you, Jyoti. Thank you, Divya. Love you all. Take very good care of yourself. Remember in prayers. Love you. Bye-bye. Take care. Good night. Good night. Thank you.